This is our April PEB board meeting. Our meetings this year are going to continue to be hybrid. Healthcare Authority staff will be on site, obviously with the exception of myself. My wife had a birthday and wanted to go to Arizona, and so I am doing this from Arizona, keeping peace in the family. Board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide has information about how attendees can turn on closed caption. We're going to do a roll call for today. Tom.
Oh, yep. Hi there.
Hey there. Welcome. Michaela. Michaela, did you?
Can you hear me?
Bingo. Just heard that. Harry.
Present.
Elliot.
Present.
Kurt.
Present.
John.
We don't have John Comerford.
Oh, John is the restroom.
No, John is joining virtually, but he's not on yet.
Oh, I see. Okay. And I'm told that Sharon will not be joining us today. All right. And we have Michael Tunick from the AG's office. Excellent. And I'm Lou McDermott. I'm going to be filling in for Sue Birch today. I believe she is on a plane and unable to make this meeting. With board members attending both in person and virtually, it's really helpful for the board to hold their questions until each presentation is done or when the presenter pauses and asks if there are questions. Board members attending virtually, we're also going to be watching in case you use your Zoom hand to indicate you have a question. There may be resolutions scheduled. Actually, there are many resolutions scheduled for action today's meeting, so the public's going to have an opportunity to provide comments on those specific resolutions during the normal procedure before the board votes. The public is also going to be able to provide general comments at the end of the meeting during the public comment period. And as a reminder, if the public has questions during staff presentations, the presenter's contact information is included at the end of the presentation. The public's welcome to email presenters during the meeting to capture your questions for response after the meeting. Dave's going to give us an overview of today's agenda. Over to you, sir.
Good morning, Chair McDermott and members of the board. Today is Votorama. But we're going to start off with a vote on the minutes, and then we'll do a little bit of a summary of a couple of pharmacy questions from the last board meeting. I'm actually going to have Jenny join me because she's much more articulate on some of the nuances, and so I invited her up to the table to help me with that. Tanya will join us to talk about the budget that is passed the last time that we met, but it hadn't been acted on by the governors. In fact, to talk about the final enacted budget and its relationship for the program. And then we will start the true Votorama portion of the meeting. We'll start off with vision. I think there's 3 resolutions for vision. In the policy rules development, we have 10 dual enrollment resolutions. I think a deferral resolution in there. We'll take a pause from voting and introduce some new resolutions for voting next month related to the Uniform Medical Plan benefit design for 2025. And then we will have a briefing on the annual rulemaking cycle. We'd like to keep you apprised as kind of the general rulemaking activity as we keep that in the formal high gear after this meeting. And then we will be wrapping up the meeting with our UMP Medicare Plan D 6 resolutions. So overall, I think there's 22 resolutions we're voting on today. Don't worry, that doesn't break a record because in SEB, I'm pretty sure we got up to 30 in one meeting one time. So, but it's coming in at a close second. But you will note that there is on the agenda that we note that there will be a transition to executive session and executive session. It was a tentative possibility. We're not actually going to have an executive session today. I just wanted to keep it on the agenda depending as where we were on the start of the rate renewal process in case there was something to bring you. But we will definitely have executive sessions from here on out. So May and beyond plan to have executive sessions. Quick couple of other reminders. If we have an emergency, we walk across the street to the visitor parking lot. And if you need the restroom, you walk down the hall. When you see elevators, look to the left instead. And with that, I'm going to hand it back to you, Lou.
All right. Any questions for Dave? All right. Today, we're going to go ahead and vote on the meeting minutes from our last board meeting on March 21st. The meeting minutes are behind tab number 3. Do we have any comments from the board? Seeing none, do I have a motion to approve the minutes as written?
So move.
Do I have a second?
Second.
All in favor, say aye.
Aye.
Any opposed? Hearing none, the March 21st, 2024 minutes are approved as written. Dave's going to give us a follow-up on our last meeting. Materials are behind tab number 4.
I'm gonna have Jenny join me. We have one set of questions that were coming up as part of Jenny's presentation related to pharmacy services. And so as we go to the next slide, there were some questions specifically about Amazon prescription services. And then just a couple of other nuances that Jenny's just gonna highlight. So I'm actually gonna turn it over to Jenny.
Good morning, board members. Jenny Switzer, UMP Pharmacy Account Manager. Super excited because I prepared for this for about 2 minutes. Just kidding, I've been following up on this for a while. So as you can see on the slide here, Amazon is in the pharmacy, the UMP pharmacy network. That was a question that came up from the last board meeting. And so far this year, there have been a little over 7,700 or almost actually 7,800 UMP claims, and for the PEB population, a little over 6,100 claims. This is all of PEB, so this includes retirees and actives in this total, which I think is a question that had come up. And another question that had come up surrounding Amazon claims, in knowing that they are in the UMP network, the question came up, are we seeing a lot more claims than filled it at other pharmacies? And it's, Amazon's actually a pretty low number. I mean, you can see how many claims have processed are there. But then also the question of, well, what about pricing? Is pricing substantially different between Amazon and going down to Safeway or Rite Aid? And just like with all of our pharmacies, where you could go to Safeway and get a different cost than going across the street to a Rite Aid, you're going to see that with Amazon as well. They're contracted for drug costs just like all other pharmacies are. And so you could log into Amazon and go to that pharmacy tab and fill your prescription for 58 cents and go to Safeway and it's 62. And then you could go to Rite Aid and it's 41. So they're right in line with the rest of our pharmacies. So you're not going to see a huge differential in that. It's pretty standard pharmacy pricing.
Then Jenny, this question comes all the time, and even I struggle sometimes to figure out the right words. Can you describe who Voda is, who Navitus is, and generally which each of those entities do?
Yeah, so there was some discussion about this at the last board meeting, and especially around who's our PBM, our pharmacy benefit manager. So MODA is a third-party administrator of our pharmacy benefits. So they are benefits administrators. They are ultimately responsible for meeting the contractual requirements that we have set forth for the management of our pharmacy benefit. So when we have questions or concerns about the pharmacy benefit, we direct those right to MODA. They directly manage customer service. They manage exceptions. They worked with us on the prescription drug list. They are responsible for a lot of other items within there, but really the oversight of the pharmacy management program. Navitus is our pharmacy benefit manager. Keep in mind, Senate Bill 5213, which goes into effect on June 1st, is actually where that change in definition of pharmacy benefit manager will be changing. That changed the definition. It excludes MODA as being considered a pharmacy benefit manager, a PBM. And so they will now be referred to as our third-party administrator, which is what they've done all along. It's just semantics of terms, right? Navitus as our pharmacy benefit manager, they do our rebate administration, so they do our claims billing, they do our network contracting, they do direct member reimbursements, and that type of work. So they're really the behind the scenes work of the claims administration with our pharmacy programs.
I think the only thing I'll add before Ellie and asked your question is, Navitas is a subcontractor of,
Yes.
so that's a little bit about the other relationship. But
Good
thank
point.
you so much, Jenny, because that was way better than how I was gonna mess it up.
I think Elliot, if I could guess what your question is, it's gonna be, but what do you guys do then?
I actually had that question.
You had that question, all right.
I wasn't
Kurt.
gonna answer. I asked.
Okay, why don't you answer mine first?
No. It's all you.
Okay, I wasn't going to ask that one, but
Okay.
once you guys didn't read my mind.
Dang it. Working hard at it. Well, let me answer it anyway, because Kurt wants to know. So what do? We manage the contract. We make sure that MODA is meeting the expectations of the contract and that their subcontractor, we don't work directly with the subcontractors because MODA has responsibility. If Navitas isn't meeting an expectation that MODA has with them, and that means that MODA hasn't met our expectation, we hold MODA accountable for that because our contract is with MODA. When, for members, where does HCA come into all this? If you have a question about your claims cost, or coverage of a drug or a prior authorization, you would call MODA because they manage our claims, right? They are the ones that have the information about how much you paid into your deductible, how much your coinsurance will be. They've got the contracts with pharmacies, so they know which pharmacies are in network. You can also go online and look at that, but that's when you would call MODA. They have customer service available. Pharmacists also call MODA to help when you go to the pharmacy. If there's an issue with getting your drug, the pharmacist will call MODA to walk through that. So where do we come in then? We're managing the contract, but also if you talk to MODA and they're like, nope, you're denied for your prior authorization and you have an issue with that, or you have an issue with anything that you hear from MODA, that's when you can contact the healthcare authority and say, hey, this is what I was told. Is this accurate? Is this right? Or, hey, I know that this drug isn't covered. Is this something that you would consider covering under the UMP benefit? That's really when you come to HCA because we tell them what benefits we are going to have for our programs, whether that's sometimes that comes from the legislature, what we're going to cover. Sometimes it comes from you all in making decisions about coverage. But that is really where HCA comes in. So you don't just have one line of support contacting this contractor that you have no relationship with, sorry, MODA, but you don't only have them. They have excellent customer service. They year over year have shown, the results of their satisfaction surveys are really high. But you also have us as a direct line. If you contact me and you're like, Jenny, I paid this much for my drug, but how much have I paid in my coinsurance? I'm gonna have to go to MODA because we don't have that information. But if you contact me and say this drug isn't covered, and I would like to have it, I might not be able to cover it right then because I don't have that much power. But we could definitely, that's when we go to leadership and say, hey, this is really in high demand. We do clinical evaluations, and cost impact studies and see if we need to cover things differently or cover drugs in a different way. So
Now we'll go to Elliot's question, and then we'll go over to Harry.
No, you can go first. I'm cool.
Maybe I'll get your answer to my question. Just one more time, tell us, please, who do PAs go to? Who makes the decision on that? MODA or Navitas or somebody else? And the other question is, are there P&T committees, HCA, at MODA, at Navitas? Are they all integrated or separate, or just real briefly explain how that would work, if it's possible?
you guys always have good questions for me. Stretching my mind here. So PAs, MODA manages the prior authorization. So when your prescriber completes that Cover My Meds prior authorization form, it gets submitted, it goes to MODA, MODA evaluates that, correct?
Correct.
Okay. And so those are managed there. And sometimes with prior authorizations, they do send those to us. We're very integrated with MODA. We work really closely with them. And so if there's a really interesting
unique
unique
circumstances.
circumstance.
As a self-insured plan, we can ultimately have, there's override processes
Yeah.
within UMP on both the medical and pharmacy side. So if there is something unusual about a claim, then the MODO or Regents on the medical side can bring something to HCA for additional clinical review and a override determination on a case-by-case basis. So there's that fact as well.
Yeah, because as we all know, nobody fits in the exact same box as the person next to them, right? And then the pharmacy and therapeutics committees. MODA has a pharmacy and a P&T committee. They review drugs and then they recommend coverage of those drugs to HCA. And we can make a decision to go with that or not go with that. HCA also has a P&T committee. I can't tell you though how they differ, but we also have one at HCA. We do look at what MODA has sent us as recommendations for coverage or benefit changes and take those into consideration and make a decision on how we'll cover. Generally, we do go with the P&T committee's recommendation for MODA because they submit a lot of really great clinical evaluation about why something that has high efficacy or why it should be covered. But there have been times that we've said, we don't really agree with that. We want to cover this at a higher level.
Just a quick follow-up question, if that's all right. I've heard of a lady from Olympia, a senior citizen from Olympia.
Oh, goodness. Good thing your mic's not on there,
I guess
Gary.
they senior
I'll let
center.
you get it.
I think that was fine. But anyway, the other question is, does Regent have a seat at the table in this somehow?
Not when it comes to prescription drug coverage. So Regents, there's drugs covered through the medical benefit, right? Those are usually medically administered drugs that you would get at your doctor's office. Those are covered under the Regents contract, but they're not involved in the pharmacy benefit administration.
One more piece on P&T committees. There's a state P&T committee that HCA is part of, and it does establish a general state formulary that is used by multiple agencies that purchase healthcare on behalf of the state. So there are some instances where it could come up where MODA's P&T has a recommendation that may or may not align with what the state P&T committee has established, and in those instances will generally be more likely to go with the state P&T if there's something there. So there's everybody seems to have a P&T committee.
There's a lot of input.
Elliot, let's go to your question.
Okay, I have a confession. I watched those commercials about sleazy PBMs. And I get calls about the sleazy PBMs. Can you describe what Navitus does as I don't think all PBMs are the same. Can you clarify and maybe alleviate some members' concerns?
Yeah, I've watched those as well. We should be knowledgeable about the things that are impactful to our members and what people are worried about, right? They're not all built the same, right? There are pharmacy benefit administrator or pharmacy PBMs that have, how do I say this? And that have higher cost impacts to pharmacies. And that's a lot of what you're seeing, where they might have contracting clauses that may add additional fees to pharmacies, which makes it just adds to their administrative burden. And there are PBMs, because PBMs manage our rebates, right? There are PBMs that keep some of that money, and we call it a pass-through, right? With Navitus, there is 100% pass-through, so the rebates are 100% pass-through. That allows us to get the most money back into the program so that we can keep the cost of our premiums low. And Navitus is our PBM. They don't add in any of those additional contracting requirements with the pharmacies that may cost pharmacies money. And sometimes it costs pharmacies money for things that those pharmacies don't really have control over. Because our ultimate goal and Navitus' goal as our PBM is to make sure that we have a really rich network for our members. And part of that is making sure that pharmacies are sustainable and that they are able to operate and run so that they're here for our members. So the big difference that you'll see when you watch those little mini series or commercials or whatever about PBMs are some of those cost impacts that are assessed to pharmacies, or that they're holding on to some of the money that should go back to the programs. And we don't have that with Navitus. It's contractual that they have to pass through all rebates to us.
Correct me if I'm wrong, but one of the theories behind this is also that a PBM will push certain drugs where they get the biggest rebates. Can you explain whether that happens with Navitus? I'm just reflecting some of the member questions.
So Navitus does do our rebate management, right? And so I don't know that I would say that Navitus pushes certain drugs. We really work with MODA on the coverage of drugs and which drugs should be covered. And it does undergo quite a bit of P&T committee review, as well as a huge amount of review by our pharmacists. All of you know Luke Dearden. He spends a lot of time looking at when there is a change that we're looking at making for a drug on the prescription drug list. A lot of work goes into, okay, so we're switching from drug A to drug B. Are they similar drugs? Do they have similar or better efficacy? Is it better cost effective? Is it available in the quantities necessary? There's a lot of different things that go into why we may switch drugs that are on the preferred drug list. And rebates does have a part in that, right? We have to keep costs low for our members because people can't afford these huge premiums, right? We want to work to live, not live to work. And so we have to keep our costs low. So if we have two drugs, drug A and drug B, they both have the same efficacy. Sometimes they're from the same manufacturer and have the same components, but this one we get a huge rebate off of and this one we don't. Well, it makes the most sense to switch to this one that has the higher rebate because it's going to keep your costs low. So Navitus doesn't push drugs at us. MODA, especially their clinical team, spend a lot of time looking at what is in the market. And a lot of times those actually come from us because Luke, not only is he witty and fun, he's also wicked smart and he stays up to date. A lot of times what we're seeing is Luke will reach out and say, this drug's is on the market now, covered at this rate for this indication and has better efficacy than this drug. Have you looked at it? And Mona's like, we were going to bring that up on Tuesday, but like Luke's just a little bit ahead of the game a lot of the time. So a lot of the time those come from us. They're not coming from Navitus.
Thank you, because a lot of members don't really know what HCA's role is. And it's good to know that the state provides safeguards. And when you hear these commercials, people are terrified. So thank you.
Tom, your mic's on. Do you have a question?
Yeah.
Okay.
I actually do. I think actually I heard the answer, but I want to make sure. So on occasion, MODA makes a recommendation and the healthcare authority can override that or change the decision that MODA recommends.
Well, sort of yes. I guess is the short answer to that. I don't know if you're asking Tom in the context of a P&T tier recommendation. Yeah, those types of things. Yes. It's essentially as a self-insured plan. The state, the board, the design isn't determined by MODA. So ultimately, the benefit design decisions are born out of the dance between the legislature, the governor's office, the healthcare authority, and the board.
Remember the other question. So let us say a new drug comes on the market. It's not, it's something really different. And there's no equivalent to it. How does the process work, whether that drug is gonna be covered by the HCA. Does it start with MODA? How does that whole process work?
In your question, Tom, is there already FDA approval or not? That's really
Oh, yes,
that's the first, yeah, that's always part of the very first question is, what has the FDA determined? And then, do you wanna take a stab or do you?
Sure.
Okay.
So when a new drug hits the market and it's FDA approved for a certain condition, it can come from HCA or it can come from MODA. You know, we look at those. MODA does bring us, these are the new drugs to market. They have an amazing team on their clinical team is fantastic. But we work with one of their clinical pharmacists, Cedal. She's on it. And when something new comes to the market, she'll bring it to us in our monthly meetings and say, these are new drugs that have entered the market for the treatment of this. Here's the efficacy. Here's what the studies have shown. This is how long it was studied for. These are the side effects, because sometimes your side effects might outweigh the helpfulness of it if we have another drug that's already there to treat it. But what you said was a new drug to treat something new that we've not seen before. And so they'll bring it to us and they will provide us like a clinical report of, you know, the drug to show, and they'll share their recommendation.
And then I
Again,
will pick up the ball on that. But one of the big questions then is we look at the hypothetical you have is a completely new drug that's like doing something that's never been done before. If that's really the case and there's not any sort of comparable or existing kind of classification structure within the existing benefit design, that becomes then a funding question as to, you know, we can't, neither the board nor the agency has the independent authority to enhance the benefit and suddenly add a complete new drug class within the plan without funding sign off on it. So that's why we end up in the decision package process talking about, oh, you know, there's this blockbuster brand new drug. You know, it's not within the existing modeling. It's not accounted for within any of the financial projections for the programmatic budget for the biennial process. We have to do projections off of that. You know, so if there is, you know, appropriate clinical value that's seen to maybe enhance the overall benefit design, then we go through the benefit design process that leads directly through the state budget, for example.
Yep. And a lot of actuarial, like the actuarial people are very involved in that. Sometimes it might have a low, usually new to market drugs do not have a low cost. I'll put that out there. There's a lot of money to be made there, but sometimes they, you know, sometimes they might have a reasonable cost, which outweighs the cost. Sometimes they might cost us $45 million a year.
And the reason that distinction, Tom, is so important about something that's brand new in your hypothetical versus something that's slightly different that kind of fits within the suite of drugs existing today is, well, if there is already coverage for X circumstance within the plan, and it's a matter of doing which of these drugs, you know, comparing something within the coverage, you know, that's a different question. You know, if there's overall funding for that disease state or whatever is being treated by the drug that already exists, then it's a question of swapping within the formulary instead of creating another prong within the formulary. When you have to create another prong in the formulary, that's where there's more funding questions.
And we don't just track when they're covered by the FDA. The MODA clinical team is looking at what studies are taking place currently. And they will let us know this is a study that's taking place and these are the results that they're seeing. And so we're never just hit with, oh, this is a new drug that we didn't know about. We know about it long in advance because they're watching it to see if it's efficacious and how that's going, and to watch the long-term effects, which is sometimes really hard with new to market drugs. We really don't know the long-term effects. We might know the 2-year effect, but so we definitely have to watch those. And it goes the other way too. Sometimes they'll share a study with us that we've been covering this drug for 5 years. But this study shows that it's not actually doing anything. But there is this other drug that's similar that is showing results. So that's another reason that we could maybe switch up the PDL.
Do you also look at the percentage of the member population that might use it?
Yes, yeah, that goes into our cost analysis. You know, it's not an exact science, But we can look at claims, MODA will look at claims to say, it's estimated that this population, this percentage of the population could utilize this drug. Based on that, based on the costs from the manufacturers, this is probably what you're looking at, and then our actuarial team does a deeper dive into that if needed.
So
Hey, Dave, I just want to do a time check and see how we're doing.
Okay, well, yeah, I think Elliot has at least one more question. Then I'll say maybe we need to put together another pharmacy presentation. I might have missed the ball and trying to do this as a quick follow-up, but go ahead, Elliot.
okay, one last question. Do you have a team of actuaries then at HCA that look at this, or is it MODA?
We work with Milliman,
Oh,
is our actuary.
But they are not HCA employees, they're also a contract.
yes, no.
Yeah. So, one more piece, the next slide, there was just a question, if we could provide the links to the support price check tools. As a reminder, you do not have to be a member of UMP to access these. You don't have a login. Anyone in the public that's interested or considering whether they want to join one of these plans, if they're another plan in our portfolio, anybody has access to these. And with that, that's all for follow-up, but I really appreciate Jenny pinch hitting. That was an impromptu presentation, and I think she did a great job.
Yeah, good thing I came in today.
Yes.
Thank you.
Thank you, Jenny. All right, next up, we have Tanya Dool, our Finance Manager in the Financial Services Division, is going to present us with an overview of the final 2024 supplemental budget materials behind tab number 5. Welcome, Tanya.
Good morning. Thanks, Chair McDermott and members of the board. Before I jump into the supplemental budget update, I do have one additional piece of follow-up that I was bringing back for Cade. At the last meeting, when he gave his legislative update on the bills that had passed, there was a question around the implementation date or the start date of 1979 around EpiPens and inhalers. And we just wanted to let you know that that will be a January 1st, 2025 change with the new. Okay, so we're going to walk through the supplemental budget update. As a reminder, the supplemental budget really takes care of things within that second year of the biennium. We're currently in the middle of a biennium, so we're really going to look at things that will happen within that second year. And the first thing that usually changes within a biennial budget is that second year funding rate. As the reminder, the funding rate is the amount that each employer pays to cover the benefits for each eligible employee. Those are paid per month. And the fiscal year 25 number changed from $1,191 down to $1,170. So this number did reduce slightly per employee per month due to some positive experience that we had within the PEB program for the last year. Next up, the Medicare explicit subsidy remained the same at $183. Or 50% of the premium, whichever is less, and that is remaining the same from the current plan year 2024, and that will carry it. On the next slide, we have our final conference budget funding. So these are the decision packages that were funded. I brought you at the retreat the list of the requested funding, and all of these were funded. So everything we requested was actually funded, which is great. And as a reminder, during the supplemental budget, we really focus on smaller alignment pieces versus larger policy changes. We reserve those bigger policy program changes that are going to make significant changes for the biennial budget as requested the legislature, and we really wait into those during the biennial process in that longer legislative session. So this year, the agency focused on alignment. And when we're talking about alignment, I'm talking about some of the benefit differences between either the PEB and SEB program or between our self-insured and fully insured program. So first up is a virtual diabetes management program. This is an app that will be available to members who are already diagnosed with diabetes and meet certain criteria. This is 6 months worth of cost. So the $612,000 is really that fiscal year funding. But as you are aware, we do things on a plan year or calendar year effective date. So this would go into effect January 1st, 2025. And this is something that was already funded within the SEP program. So we're aligning this now with the PEB.
And just to put another way, Tanya was saying there's two ways to think of alignment between fully insured and self-insured between the programs. This actually, UMP and PEB was the one corner of all of those permutations. The fully insured plans at PEB already have a diabetes management program, and all of SEB already does. It's just this little quadrant that is aligning. So it's really aligning for both of those perspectives that Tanya was describing.
So next up, another piece of alignment is around breast exam screenings. Last year during session, Senate Bill 5396 was passed to remove the cost sharing associated with diagnostic and supplemental breast exams in the fully insured plans. Both PEB and SEB, the fully insured plans, that started this most recent plan year. So we requested funding to align that within the uniform medical plan in both PEB and SEB, and that was funded. So effective January 1st, we will be looking at bringing that to the board.
In fact, Ryan will be bringing that later this meeting.
Okay. Probably should have looked at the whole agenda. All right, and then next up is vision hardware. I think we've brought you guys along this journey over the last few years. First with the carving out of the vision from the medical plans for the non-Medicare risk pool, and that was already funded. This is a second piece in that, which was increasing the hardware allowance from $150 to $200 every 2 years, and that was funded starting January 2025. So that would increase the hardware allowance by $50 for each member every other year. And then last up, we had a decision package related to FTEs. I do want to stop and talk a little bit about this one for a moment. The FTE decision packages can look a little funny math-wise when you break these down. This funding is the full year, so $606,000 for a full year because these would start on the start of the fiscal year. Well, the narrative on the slide says 4 FTEs to support the increasing needs for member outreach, customer service and communications and procurement support related to Medicare resources. There's an additional 1.2 FTEs that was also funded as part of this for agency indirect costs. So when we add additional FTEs into the agency, there's also additional things that have to happen to support these FTEs. There's a baseline calculation that we use within our FTE decision packages. So really, this would be $606,000 for 5.2. And it's also a combination of salaries, benefits, which is a large cost. It's just not the salary that an employee makes, as well as things like IT support and a desk and things like that. So I wanted to just point that out because we have received some questions around the costing of FTEs.
And in case you want an example of when Tanya said 1.2 FTEs indirect, what's an example of that? I know somebody here who's head of state HR that knows that an example of that is employee resource and HR departments throughout the state. Many times when a new program is added to a state agency, the last thing that's thought of is adding another to the team. And if you suddenly have, let's say with the SEP program, we added 50 FTE to this agency, we did remember to ask for an HR consultant, but many times that is not funded. And so things like that, or contract support, in an agency's contract team, those are all examples of
Paying the payroll.
Payroll.
It's actual FTE.
So it's kind of the incremental part that is always a very challenging part for agencies to work on getting, because most of the time it's like, well, I need a 0.1 FTE, and 0.1 adds up after 10 requests, and you might not ever get that FTE. And so we took a different approach as an agency this year, and we're pretty successful in being able to kind of try to recalibrate some of those indirects resources that have not been built up over the years.
Thanks, Dave. Yeah, that's good. So I'll move on, but feel free to interrupt or ask questions as we move on if something else comes up. Next, we're going to move on to things that are in different sections of the budget, not necessarily related to direct funding requests. In section 212 of the final conference budget, there was language related to a consolidation legislative report. And it stated that $100,000 would be provided so we can produce a report to the legislature by December 1st. The necessary statutory and program changes required to achieve consolidation of the PEB and SEB boards into one single governing board, the PEB non-Medicare and SEB active risk pools. As a reminder, there are currently 3 risk pools. This is just looking at the non-Medicare PEB risk pool and the SEB risk pool, not doing anything with the Medicare risk pool. So just looking at aligning the 2 with active employees and the PEB early retirees, as well as existing eligibility provisions and benefit offerings into more aligned plans. The report should also consider ways to engage with our impacted participants, options to maintain eligibility and ensure equity, and data and findings from previous reports related to consolidation. So really, this report builds upon previous consolidation reports that the agency has completed. And some of those components that were in the 2020 consolidation report would be updated in this new report. Again, I think we really just want to reiterate that this report would provide insights to the legislature, but it's not a formal policy decision. And any change to board structure or risk pools would require formal legislative action. And if anybody wants to look at the formal report from 2020, we can definitely follow up. We can send that out to you. It's public on the internet, so we could get the link over to you. It's really informative. And in addition to that, there was another version of a somewhat consolidation report from 2018 that looked at the consolidation of just the risk pools. So it didn't address full consolidation, but it addressed risk pools, and we brought that to both the PEB and the SEB board a few years back. So we can also share the link for that.
Yeah, Jessica will follow up with a set of links for those two reports. And Tom has the first question.
No,
He just wants.
Oh, you want the reports? Okay, got it.
yeah.
We'll just get them to everybody.
Yeah, Jessica will send it out to the entire board.
And then, of course, as we work through drafting the updated legislative report, we'll bring the board along the way and share with the board as we develop that new report.
I'm just curious, that existing eligibility provisions, so within the entire spectrum of SEB and PEB, can you expand exactly what the eligibility provisions would be? Is there any, would there be any difference or any change?
So right now, Tom, if you looked at the two core board statutes, RCW 4105-065 is the PEB statute. And I can't believe I'm not 100% positive, but I think it's 4105-740 is the SEB statute. It's not 740, it's 720. But both of those include the core eligibility requirements for each program. And the way I always describe PEB is, it's not about, there's multiple ways that you could be benefits eligible as an employee for PEB. There's like 6 or 7, maybe even 8 ways. I think it goes like A through H as categories. The core eligibility way that most people qualify is like a state agency is that you are anticipated to work at least 80 hours for 6 months. And then after that, once you have established eligibility, you maintain eligibility by being in pay status for at least 8 hours in a month. If you're not that, for example, the next most logical bucket of eligibility is in higher education, that we have what's a 2-year averaging that relates to hours in and out of the quarter system. And there is, so higher education often focuses on that prong. There's the eligibility if you're an elected and appointed official, if you're a judge, if you're a legislator, there's if you're a seasonal worker. So our agencies like Fish and Wildlife, the Department of Agriculture will look at, a fruit picker in Eastern Washington and stitch together apple season and cherry season and blueberry season and put those together. So we have a seasonal worker provision. We have the higher education averaging. We have the bread and butter 80-hour eligibility. We have elected officials. Those are all ways you could be eligible in PEB. In SEB, it's completely different. There are at least 2 core ways. You have to be anticipated to work at least 630 hours in a school year. So there's this very cyclical nature in the SEB world where every September is a new school year. I know that you know that. And so there's a potential, an eligibility redetermination that essentially happens every August and September for the start of the new school year. And there's a lot of turnover. There's a 10 to 12% turnover with the workforce in the K-12 system. There's also no maintenance rule. That 8-hour rule to maintain benefits doesn't exist in SEB. But just like the cyclical nature of work doesn't really exist in the same way in PEB that exists in the K-12 system. And so this is essentially the, it's not that eligibility, any of those would fundamentally change, but the way we describe it in outreach and training helps state agencies and PEB employers, you've got to check all of the boxes in eligibility. Just because you check the 80-hour rule, you got to make sure that they're also somehow not a seasonal worker, and double check that somehow you don't hire an elected official, or, you have to check each of the prongs. And so this is just, the idea would be just, you're literally just kind of collapsing them together, but not necessarily fundamentally changing eligibility. And I do want to highlight, because I think this is important for how this consolidation report came to be in the budget. There were some interested external stakeholders that brought to the legislature a question about furthering consolidation of various purchasing to maybe one day have something on the single payer universal scale, and eventually, you know, you have to consolidate more and more things at some point in order to achieve that goal, if that is your policy goal. And so, as often happens when the legislature is thinking about something with the budget or a bill, they ask the agency for technical assistance. And so they say, this is what we're trying to achieve. State agencies perform, you know, advanced work for legislators and legislative staff all the time. You know, we're just providing insight on the best way to write whatever it is the goal that's trying to be achieved for whoever is asking it. And as nonpartisan a way as possible. It doesn't matter what it is, we try to write it, because if something's going to be implemented, agencies really just like to be able to have the best way to implement it, no matter what, at the end of the day, be able to implement legislation. So we were obviously, we were consulted and are aware of this legislation because we were asked for technical assistance on it. But I did want to clarify that, because some people have asked, like, did the agency write this? Well, we provided technical writing support. It didn't get initiated from the healthcare authority. It got initiated by external groups. And, you know, I don't know that it would have, you know, it would have necessarily been in the budget if that hadn't been it, because the agency didn't bring it forward. At the same time, no secret that I'm willing and able to talk about any consolidation that anybody wants to talk about at any point. So, you know, talk about the worst secrets kept in Olympia. I think that might be one of them, if I can elevate myself to that importance. But it's, you know, it's a conversation that we can have, and the agency has had it in some way, shape, or form since I was in middle school, before I was even on the West Coast. So it's been a 30, 40 year decade, 30 to 40 year conversation in some way, shape, or form. I think the most important thing to know is, if you go back, you could stack up all the consolidation reports that have been done since the early 90s, late 80s. Really, all the ones that happened before 2020 are kind of a different point in time than the 2020 report, because by the time the agency was doing the 2020 report, SEB was well on its way to being launched as that report was being written. And so the earlier reports were all about how to consolidate K-12 and what would be the mechanisms for taking 295 school districts and collapsing them into a system or a separate system. The 2020 report then was the first one that was really about, okay, well, now you have two systems. That's a different kind of question to think through than a total consolidation of a decentralized system that existed in K-12 before 2020. So there is some relevance to the conversation for the prior reports, but really the most relevant report, in my opinion, is the 2020, because it comes from the standpoint of an existing two programs that are state run already. So just wanted to give a little bit of context there. Tom has a question.
Well, so is that a product of the clearing case?
In the strictest sense, I would say the answer to that is no, but the decision by the legislature to consolidate K-12 was included in what people call the McCleary bill. So it wasn't mandated by that litigation, but it was a policy decision that the legislature made at the same time as they addressed state funding questions on K-12. Okay. Elliot.
Did you do a fiscal report along with your analysis?
In 2020?
Your latest recommendation.
Yeah, there was some fiscal analysis done in the 2020 legislative report. It would be a little bit outdated, but yeah, some of that would be in the 2020.
Okay, thank you.
And because of the timing, the experience that we actually knew about the SEP program at the time would have been largely projected.
Do you anticipate, this may not be a fair question, having to do the report again?
I think we're still early in the planning of the new report, and while the report doesn't say specifically, specific cost things, we will look at the combining of the two risk pools, which involves looking at the cost of the two programs. But combining the two programs is not going to save significant costs overall, right? It will just reweight which programs probably one might pay a little more, one might pay a little less. Because we're still gonna have the same number of lives that are covered. I mean, there's probably a small amount of administrative efficiencies, but when we're talking about covering the actual lives, the cost of the claims and the premiums, it's
still
still
gonna be $5
gonna be
billion.
what it is.
Still,
One program would be less. Which program would that be?
I'd have to go refresh because the data is outdated, but as a reminder, the PEB program includes the early retirees. And the SEB program is just active employees. So currently, some of the rates in the PEB program are already higher just because they're rated with those early retirees who are generally a little older and more expensive.
But I think it's important
There
to
are a
say
lot of
that
nuances.
there are a lot of nuances and just the answer may not be the same every year
Yes.
as well. And so there's not, there is that one structural difference that might tip the scales sometimes, but it's not inherent that one program would always be advantaged or disadvantaged in the calculation. And that's part of the analysis that we'll be doing for that particular problem.
Okay, thank you. And is how the board will be restructured part of that process too?
Part of-
Because you have two boards, how will that?
I'm not sure I understand the question, cause I'm,
You have a PEB and a SEB board now.
Yeah.
If they're gonna be consolidated, what will that look like?
oh, okay, so I was figuring out how you were associating that with the risk pools, and I was like,
Sorry.
it's like,
Different topic.
it's like, yeah.
But the same.
Paid break, next question. Okay, got it. I just was like, I'm still tying it to risk pools. Yeah, there are a lot of ways that you could talk about how to constitute a board. You know, importantly, this report does not ask the agency for a recommendation. So I think we're anticipating that we can say, here are ways that you think about having a board. And then the legislature will have to decide, you know, what do we want? You know, there's a couple of different ways that you could say to constitute a board. And I know that there's a lot of interest because there are, you know, several of you represent constituencies and the same happens on the subboard. And so there will obviously be a lot of intense interest there. And we're aware that that is an important question. I think we'll end up describing, you know, you could, you know, off the top of my head, one thing that I think describes like, what would a board look like if you had proportional representation based on the membership that's served? Like, that's a way you could think about how to describe a board. And so that's the type of the lens we'll be taking. We're not gonna say the board should be this. If there's not a recommendation asked for, we're gonna say, here are ways to think about how to account for it. And there's nothing that suggests that, you know, that we wouldn't be describing things from there needs to be representatives like there is today.
Is it safe to say, I wanna make sure I'm not making any assumptions, like, when I think about the legislature giving an agency money to write the report, the way that we've been consulted before is we do it from a somewhat agnostic perspective of saying like, hey, you're asking us for insider information on how this works, so we're gonna give you hopefully like unbiased information that says, here's what it could be. And we try to remove all opinion on whether or not we think it's a good idea or not, to just give the legislature the opportunity to then say, okay, then what are you gonna do for proposed legislation in future years to say what you should do? And then we have the opportunity to kind of weigh in and say, we think this is a good idea or not, through different avenues. Is that kind of like what stage we're in right now?
Yeah, I think that's a great trigger, especially my mind, there's two different types of reports, and this is the type of report that you just described. Because the other type is asking for a specific recommendation to do something, and then it's harder to be agnostic when you're asked to make a choice and recommend something, but there's no recommendation here. So what you described really is the tenor of this type of report. And Kurt?
This is going back to the final funding rates. Perhaps it's a question better for our legislature or the governor, but you know, looking at the fiscal year that was in the budget last year, it was 1191. We're at 1170. So I'm just curious what the thought was when we have plans with significant increases to then fund it at a lower rate.
Okay. Yep, I can tackle this, and I think
To bring rates down for members, not.
So I think there's 2 points. This is not members. Remember, the state's contribution towards healthcare is benchmarked off of the Uniform Medical Plan. So,
Right. But it still empowers those that would negotiate that with what they have as a budget. And it's millions of dollars less to come to the table with, right? Right. But go ahead, finish your answer.
No, I don't, go,
you can go.
no, go with the description of the describe it. I think we might need to circle back, but keep. Just,
I was gonna go to the different points if you wanna add on to this.
go ahead, you go first.
I was gonna go back to kind of the timing of how the funding rates are set. So this fiscal year 25 funding rate that got reduced is to cover rates for 2025. And when we had set the budget, we were 2 years back. And we were looking at experience from actually 2020. So we're in the middle of a pandemic experience that we were using to develop the actual cost projection for this fiscal year 25. And now we have multiple years experience where we were able to reduce some of that margin we had for COVID costs in there. So it's really a timing issue on why the second year changes, and it will change mostly every single biennium. It's a lot driven by the timing. So we had originally built in costs that we thought were gonna be higher as a result of higher COVID utilization years when we were looking at the projections for both 24 and 25. And so some of the funding rate actually, when we changed fiscal year 25 is also because of things in 2024 are better also, because we're still in 2024, but we cannot change that. So that carries over into our total projected surplus or deficit at the end of the biennium, which is balanced on the fiscal year 25 also. So when the legislature is considering where to set the funding rate for the program, they're looking at that total bottom line surplus at the end of the biennium, and they're targeting it near zero as much as possible. So when we're able to reduce it from 1191 to 1170, that's actually a cumulative surplus gain over a couple of years that is driving to that. So it's not the actual net cost of the program. The net funding rate is actually a lot more stable when we look at that year over year. This is the gross funding rate, which takes into consideration years where we need to either fill a gap because we've ended in a deficit, or we have a surplus that we can use to buy down this funding rate. And that is what's happened. We built up a surplus because we had over projected in a year and had lower claims experience. We build up a surplus, then the legislature can choose to use that money that's in that bank to buy down artificially that funding rate. Does that help a little bit?
Yeah, I don't like the answer, but it helps explain it. Thank you.
You went where you were
Okay.
gonna go, and then you just said it better.
Thank you.
I'm just a little confused. On this sheet, it says, the funding rate for 2024 was 1,145.
Correct.
And then for next year, it's 1,170.
Yeah.
And you quoted 1,191.
That's what we had in the biennial budget for fiscal year 2025.
So last
Original.
session, not the one that ended like 30 days ago, but the one that ended 2024, sorry. 2023, I said I don't know what year it is. In 2023, the legislature passes a biennial budget, and in that budget, they had a funding rate for the first fiscal year and the second fiscal year. In the supplemental budget, they revised that second fiscal year number. And the first year when they passed it in 2023, it was 1190. This time, they revised it in the supplemental budget process by changing that to 1,170. So they leave the current fiscal year that we're already in stable, and they make all adjustments in the second year's fiscal funding rate. Which is why I said, I don't know that there's any biennium where the second fiscal year in the biennium, it always changes at some. I don't
Just
think
because
it's
it
ever
wasn't
not
on-
changed.
Wasn't on the sheet of paper.
Yeah.
I can make sure next time I like do a strike through and stuff. I just had it in my talking points to let you know what the previous number was, but I'll make sure that I strike that and put the new number for you. All right, so next slide. Continuing on the theme of additional language that was included in the budget. In section 902, which is where these funding rates we were just describing are, there was language under those funding rates that states that the rates are not sufficient to add coverage of prescription drugs for the treatment of obesity or weight loss. The authority shall not add coverage of prescription drugs for the treatment of obesity or weight loss without a specific appropriation from the legislature. Nothing in this section requires removal of any existing coverage of prescription drugs to treat diabetes. And this really fits in well with the conversation that Dave and Jenny were just having with the board on new drugs hitting the market and the board's authority to increase or enhance benefit coverage. So as you're aware, like Dave described, there's really two paths that the board can take to enhance benefits. And one is bringing ideas that then get introduced through the decision package process, are then introduced through the legislature, and the legislature takes action to either fund or not fund that specific benefit. Just like the benefits I just walked through, right? All of those decisions went through the legislative process and were chose to be funded by the legislature. The second option that the board typically would have is the ability to swap benefits in a cost neutral way. So if the board wanted to enhance a specific benefit, they would have to come up with a creative way to make that cost neutral to the program. One way would be cutting other existing benefits, or something like we did a few years ago with the CAM benefits. If you remember back a couple years ago, we increased the chiropractic, acupuncture, and massage visit limits by changing the way the cost sharing and copay structure was set so that it was done in a cost neutral way. So what this is saying is that the board actually would need a specific appropriation to do that, but we wanted to point out that even if there was the ability to do that swapping, the cost that we estimated as a result of the fiscal note on 6182 for these drugs really wouldn't be feasible for the board to swap another benefit for due to the size of that cost. Along those lines, in section 212 was also a legislative report requirement stating that by December 1st, the authority shall submit a report to the legislature describing options and a recommendation for future coverage in the Uniform Medical Plan for FDA-approved GLP-1s for the treatment of obesity and weight loss. And I think like Kyla was pointing out, this one actually does say a recommendation. So this is another legislative report that the agency will be working on and is due December 1st. Are there any questions on this slide?
That first one, section 902.
Yeah.
So, I remember, I think it was when Kate actually was doing his, legislative report. And at that point, he said that the introduction, of one of the bills was just to kind of get the ball rolling on talking about these weight loss drugs, but there was little, what would be the term? I think the term was something like, I don't think they're gonna do anything with it, but they just wanted to start the conversation. Is that a correct assumption because of the fiscal impact of using those drugs?
I don't know that I completely speak to the mindset that the legislature is having, but what you're referring to, Tom, is there was a Senate Bill 6182, that talked, it was a bill to include or expand and add coverage for obesity treatment drugs into a couple of different plans, and it included the at least part of the PEB program. I can't remember off the top of my head now if it was the entire portfolio or just UMP. And depending on when Cade was giving his presentation, we might have already passed a cutoff and it never made it out of the policy committee. But as is often the case, that state agencies are aware of, when a bill fails to pass out of policy committee, it often ends up resurrected in the budget as a report. And here we have section 902, or section 212 on a report. So, you know, if something doesn't, for whatever reason, it doesn't have momentum in the legislature, often a report, many times it can lead to a report of this nature. So I don't know exactly what the sponsor's true intent was, but they dropped a bill. There was a hearing. It didn't pass out of committee. And now there's a report on it. And so that's what we really kind of know. So if the goal was to get the conversation started, it looks like that goal is being achieved because there'll be a report on it to further conversation.
Other questions? Okay. And then last up, there was additional language, which I believe I brought at the retreat, regarding RDS revenue, and this language was in the governor's budget, and it's in the final conference budget in section 902. And this is the board's authority to forego the federal RDS, the retiree drug subsidy, in the Uniform Medical Plan, only to leverage additional federal subsidies via adoption of a Medicare Part D employer group waiver plan to reduce member premiums for our Medicare retirees in the Uniform Medical Plan, classic Medicare. So the language is still there because, as you know, the Uniform Medical Plan portion of the total retiree drug subsidy revenue that the state collects and puts in the general fund, the Uniform Medical Plan is the majority of that total revenue. And the board does not have direct authority to create additional expenditures for the state. And because this is not really even HCA dollars, it goes to the state general fund. This language was just there to make sure that if the board chose to move forward with Part D and forego the RDS revenue as a result, that the board has the authority to do that. So this is really time to vote on that. And that was my last slide. So any questions on any of the other slides?
Thank you, Tanya. All right, next up, we have Vision Benefit Design Update, Beth Heston, Procurement Manager, and Stella Ing, Policy and Rules Coordinator in the ERB Division, are going to bring back a few resolutions regarding changes to the PEB program's Vision Benefit Design for voting today. Beth and Stella's materials behind tab number 6. After Beth and Stella review each resolution with us, I'm going to go ahead and ask for a motion to adopt. And a second, I'm going to invite the public comment on the resolution. And I'm going to ask for discussion from the board until we're ready to vote. We'll ask for public comments specific to each resolution one at a time, make sure to raise your hand to give comments on the resolution that your comments are about. Beth and Stella, over to you.
Good morning, Chair McDermott, and members of the board. I'm Beth Heston, and I am the Vision Account Manager for PEB at the moment. Next slide, please. Our objectives today, as Lou outlined, are to review. I'm going to review proposed changes to the PEB Vision benefit. I'm going to talk today about vision plan service areas, because there were some questions at the last board meeting. And then I'm going to pass things over to Stella to guide you through the resolutions related to this action. I just want to reiterate these changes are for the employee and non-Medicare retiree vision benefit. This change has no effect on PEB Medicare retirees. Medicare retirees will continue to receive their vision benefit through their Medicare plan. Next slide. So what is covered in the vision benefit for employees and non-Medicare retirees? A yearly routine eye exam for members, a pair of glasses and eye exam for dependents under 19, either a pair of glasses or a pair of contact lenses each year. Then we get to the actual hardware benefit, which is $200 every 2 years to be spent on a pair of glasses or contact lenses in lieu of frames and glasses. Beginning in 2025, this will be the benefit. Also beginning in 2025, the 2-year reset on the hardware allowance will begin in numerically odd years. So it'll start in 2025, it'll reset in 2027, 2029, and so forth. The reason that I'm making such a point about that is at present in PEB, folks, their reset date is based on when they last got glasses. But in SEB, it's based on even years. So we're switching everybody to odd years. Now, if you're hired in an even year, you get 2 bites of the apple, because you'll get your benefit the year you're hired, and then you'll get a new benefit when it resets the odd year.
So just to drive that home even more pointedly, you could go get a pair of hardware on December 31st of 2024, and then go back the next day on January 1st of 2025, and you have $200 on the 31st and another $200 on the 1st. Whereas today, Beth and I's 2-year reset is
I just went 2 weeks ago, so I'm.
And I have no idea what mine is, but it's certainly not the same. And now everyone will be January 1st. Reset.
Next slide, please. All right, just as a reminder, there are,
Ask a question about the dependents 19 and under receive a free pair of glasses. That's
Yeah.
a lot of statement.
yeah, what they
Within
receive
some limits,
is,
yeah.
yes, yeah, dependents receive a pair of glasses and lenses or contacts in lieu of glasses every year. There's no copay, but the frame costs are limited to what we call usual and customary. So, they can't have their Gucci lenses with the emeralds and the diamonds. What is the usual cost?
And we all kind of chuckle about that, but this is really a manifestation of change in the ACA, the Affordable Care Act. And it was a journey to get to usual and customary because that wasn't how a lot of places originally implemented. And there were people who were getting higher end designer glasses, and that prompted the conversation within the payer community to work on a usual and customary charge that was a reasonable cap to ensure the spirit of a free pair for people under 19 was available without paying for designer hardware.
That help? Okay. I just want to remind everyone that there are eye diseases that will still be covered under the medical benefit. Some eye-related conditions that have always been handled under medical benefit are treatments of infections and injuries to the eye, any eye surgeries, and monitoring of and treatment of diseases like glaucoma, cataracts, diabetic retinopathy. Those will continue to be covered by our PEB medical plans. Next slide, please.
Elliot?
Oh, sure, Elliot.
I just need a little clarification. I just want to make sure. So this page 5 only applies to active. Am I correct? Or does it apply?
No, that's coverage on medical plans for everybody.
Oh, it is.
Yeah, every medical
Yeah,
plan,
but the page before says non,
right,
and this applies to everybody.
right.
Page 5.
Yes, but page 5 also applies to retirees because all medical plans and Medicare plans cover disease of the eye and
Thank you.
diabetic retinopathy and glaucoma. Those are all covered.
So Elliot, this is interesting. We look at these slides for weeks to prepare for the meetings. On slide 4, the title, you're right, literally says vision benefit for employees and non-Medicare retirees. The focus of that is because the top bullet says what is covered in a standalone benefit. And we were focused on conveying standalone benefit is what will be the future state for employees and non-Medicare retirees. There is not going to be a standalone benefit for Medicare retirees. But at the same time, all retirees for their vision benefit are moving over to these components. We'll have a $200, for example, a Medicare retiree will also get the enhanced $200. They will also get the bump from $150 to $200. The part that is just for non-Medicare and retirees employees is the fact that it will be a standalone benefit. And that's why when you move to slide 5, and Beth says, but the medical plans like today will continue to do this like today for non-Medicare retirees, and that stays the same for Medicare retirees too.
It's helpful because our members, as well as me, we're confused what page apply to.
And we were trying to make sure that our message was very clear, and we ended up actually making it less clear. The Medicare retirees continue to get the same benefits. They also get the increase on their hardware, but they'll get it through their Medicare plan. The employees and non-Medicare retirees are the ones that are moving to our new fully insured standalone vision plans. So, all right, next slide. All right, I apologize, despite Dave's order, I neglected to add a legend to these slides. But the areas in blue are the counties covered by Davis Vision in their service areas. So every one of those blue counties, you can use your Davis membership to see a provider. Next slide.
That's the other way, there are providers in the counties that are shaded that are contracted with Davis.
Yes.
Because you don't have to live in Okanagan County to see an Okanagan County provider, you just have to drive there.
Yes. All right.
And Kyla?
So, and I'm jumping ahead, but Wakayakum, Columbia and Garfield don't look like they're covered by anyone.
Part of that is because there aren't any providers who wish to participate. And a couple counties, there are no providers at all.
Period.
And so we can't make providers participate. And in fact, you know, some of them make business decisions not to choose networks because it may limit how much they're reimbursed for their service.
But and that's kind of the nuance that I was trying to highlight, is if you live in Wakayakum County, it's simply that there's not a provider there that's in the network. You can use the benefit anywhere else, well, except Columbia, but you can use it anywhere else.
Yeah, you can drive to another county, and many of those folks
Are aware of that
are aware of
limitation.
that limitation.
Drive to another state.
Yes, but there are some limits to which vision plans cover out of state, but there is out of network coverage on all of them.
Yeah, I was thinking down in the Vancouver area,
Yeah.
over there by the.
Yeah, if they want to go to Idaho or
Across
to,
the river.
yeah. They may have that option. They would have to look to find a provider that accepted Davis Vision. Next slide, please. And the pink counties are IMED Vision Service Area. You can see they're in a few more counties. And lastly, the next slide is MetLife Vision Service Area. MetLife will also be our default plan because they cover the most counties. If someone doesn't choose, they will be enrolled in MetLife. But we want them to choose the plan that works best for them. And we're going to do a lot of education between now and open enrollment to teach folks how to look up a provider, how to find a provider who accepts their plan, and what they need to do to use this benefit. And with that, I will turn things over to Stella.
Thank you, Beth. Good morning, Chairman McDermott, members of the board. My name is Stella Lee, Policy and Rules Coordinator from the IRB Division. The board's authority statutes are placed in tab 7, slides 5 and 6 for your reference. And so, next slide, please. Here are the 5 policy resolutions for action. I will go over each resolution briefly and describe what they are before I hand it over back to Chair McDermott. The first resolution, PEB 2024-12, addresses fully insured vision plans. I will go over that first before I address the last 4 resolutions that describe enrollment policies. And we do have slightly amended versions on resolutions PEB 2024-13 and 2024-14. And I will go over those slightly amended versions before I pass it back to Chair McDermott for the vote.
So real quick, just to orient you, because we're gonna repeat this theme, this is Stella's first of 4 stints at the table today. We'll have her present the first resolution whenever there's, in different parts of the day, is the benefit design resolution. And then after that is a series of eligibility and enrollment resolutions. Stella's gonna tee up the benefit resolution, then we'll have Lou walk through the motion voting process on that. And then after that, turn it back to Stella to walk through the eligibility ones. Because if for some reason, we're trying not to be overly presumptuous about the outcome. And so we want to make sure that you have to separate that kind of distinction between setting a benefit design and then all the eligibility and enrollment resolutions that come related to that, so to speak.
Thank you, Dave. So slide 12, please. slide 13. So resolution PEB 2024-12 is the fully insured vision plans benefit design resolution. And we received no stakeholders feedback on this resolution. Are there any questions from the board? If not, then I will pass it to Chair McDermott for the vote.
And Lou, I just want to make sure that everyone's aware that the appendix to this presentation has a copy of the benefit design that was presented on March 21st, 2024, so that you have it all together. It kind of starts up in the slide deck on page 25. You'll start to see charts that describe co-pays and benefit structure. That is the benefit design that was presented last meeting.
Awesome, thank you. We're going to go ahead and take a vote on resolution PEB 2024-12, fully insured vision plans. Resolved that the benefit design for the embedded refraction vision exam and hardware coverage for the employees and non-Medicare retirees included in the prior board policy decisions and resolutions is rescinded and replaced with the following. Beginning January 1st, 2025, the PEB program will offer standalone fully insured vision plans by iMed Vision, Davis Vision, and MetLife Vision as presented at the March 21st, 2024 board meeting. Do we have a motion to adopt?
So moved.
Is there a second?
Second.
Do we have any comments from the public?
I'm for McKinsey, and I'll help you manage this all day, Lou.
Thank you.
I don't see anything yet, but I know I don't, I at least want to pause and make sure people are struggling to raise their hand, that we give them an ample opportunity. Wait a couple more seconds. Not seeing anything.
Any comments from the board? All right, this is going to be a roll call vote starting with Tom.
Yes.
Michaela,
Yes.
Harry,
Yes.
Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution 2024-12 passes. Stella, back to you.
Thank you. The second resolution, PEB 2024-13, addresses employees who are eligible for the PEB vision plan as of December 31st, 2024, and did not make an election during this annual, that they will be auto-enrolled in the PEB vision plan effective January 1st, 2025. The dependents on the account will be enrolled in the same PEB vision plan as the subscriber. We have a slightly amended version with words underlined in red, and it reads, all employees who are eligible for the employer contribution towards PEB benefits as of December 31st, 2024, and did not make an election during an enrollment period established by the Healthcare Authority in 2024 will be auto-enrolled in a PEB vision plan as designated by the director or designee with an effective date of January 1st, 2025. Any dependents on the account that are enrolled in a PEB medical will be enrolled in the same PEB vision plan as the subscriber. And we have received no stakeholders feedback on this resolution. Are there any questions from the board?
I'll just also quickly highlight on this, because you'll see this theme throughout the day. Your board packet, like slide 14 here shows the red line of any changes when Stella has a revision to present, and then the very next slide is just the clean copy, final version. That's why if it feels duplicative, we're trying to show you the track change, so to speak, and then give you a clean copy for voting on it. So that's a pattern you'll see with the revision structure.
Hey, Dave, I'm just asking, did John join us?
He has not joined, and as a reminder, he's non-voting for purposes of resolutions. He can make motions in seconds, but he's not on your list for a roll call because he does not have statutory authority for a vote.
I appreciate that. Thank you. And we're ready for a vote on resolution 2024-13?
Yes.
All right. Resolution PEB 2024-13 default enrollment. If an employee did not enroll in the PEB vision plan during the annual open enrollment in 2024. Resolved that all employees who are eligible for the employer contribution towards PEB benefits as of December 31st, 2024, and did not make an election during an enrollment period established by the Healthcare Authority in 2024 will be auto-enrolled in a PEB vision plan as designated by the director or designee with an effective date of January 1, 2025. Any dependents on the account that are enrolled in PEB Medical will be enrolled in the same PEB vision plan as the subscriber. Is there a motion to adopt?
So move.
Is there a second?
Second.
Thank you, Elliot. Are there any comments from the audience?
Looking, giving people an opportunity to raise their virtual hand. I don't want to move too fast, but also not too slow. Fill the awkward silence. And we're just not seeing anything.
Any comments from the board? This again will be a roll call vote starting with Tom.
Yes.
Michaela,
Yes.
Harry,
Yes.
Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution 2024-13 passes. Stella, back to you.
Thank you. Slide 16, please. Resolution PEB 2024-14 addresses non-Medicare retiree enrollment requirement. We're bringing you a slightly revised version to be clearer on the intent. And it reads, a non-Medicare retiree must enroll in PEB Medical to be able to enroll in PEB Dental, in PEB Vision, or in both PEB Dental and PEB Vision. And we received no stakeholders feedback on this resolution. Are there any questions from the board?
All right, we're going to vote on resolution PEB 2024-14 non-Medicare retiree enrollment requirement. Resolved that a non-Medicare retiree must enroll in PEB Medical to be able to enroll in PEB Dental, in PEB Vision, or in both PEB Dental and Vision. Is there a motion to adopt?
I move.
Is there a second?
Second.
Any comments from the public?
Watching, giving people an opportunity to raise their virtual hand. Not seeing anything at the moment. We'll wait 5 more seconds. A fast 5, probably. And we're not seeing anything, Lou.
Any comments from the board? This again will be a roll call vote, starting with Tom.
Yes.
Michaela,
Yes.
Harry,
Yes.
Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution 2024-14 passes. Back to you, Stella.
Resolution PEB 2024-15 amends PEB 2021-12, amending resolution PEB 2020-04 relating to default enrollments for an employee who fails to make a timely election. And we received no stakeholders feedback on this resolution. Are there any questions from the board?
Just remind everyone about this. Your appendix also has the red line. When there's not one that's being revised in the deck itself today, your appendix has the red line of what was presented last month. On this one, just because I know that this particular rule is just one that people can struggle to grapple with, it's the third sub-bullet, enrollment employee only vision coverage, which is the primary piece that needed to be added into this overall rule about what happens if somebody fails to make an initial election. So.
All right, we're going to take a vote on resolution PEB 2024-15, amending PEB 2021-12. That is amending resolution PEB 2020-04 related to default enrollments for an employee who fails to make a timely election. Resolved that amending PEB 2021-12 to read the default election for an eligible employee who fails to timely elect coverage will be as follows: enrollment in employee-only medical coverage, enrollment in employee-only dental coverage, enrollment in employee-only vision coverage, employee and basic life insurance, employee and basic AD&D, enrollment in employer-paid long-term disability insurance, and enrollment in employee-paid long-term disability insurance at the 60% coverage level. Is there a motion to adopt?
So moved.
Second.
Is there a second? Thank you. Are there any comments from the public?
Watching for Mackenzie. Did an excellent job surveying hand raising. Enough of a pause, back to you. There's no comments.
Any comments from the board? All right, this again will be a roll call vote, starting with Tom.
Yes.
Michaela,
Yes.
Harry,
Yes.
Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution 2024-15 passes. Stella, back to you.
Thank you. Resolution PEB 2024-16 amends PEB policy resolution error correction adopted on July 16, 2014 by including PEB vision, and we received no stakeholders feedback on this resolution. Are there any questions?
All right, we're going to take a vote on resolution PEB 2024-16, amending PEB policy resolution error correction adopted on July 16, 2014. Resolved that if an employing agency fails to enroll an employee in benefits, medical, dental, and vision, enrollment will be effective the first day of the month following the date the enrollment error is identified, unless the healthcare authority determines additional recourse is warranted. If the enrollment error is identified on the first day of the month, enrollment is effective that day. Is there a motion to adopt?
So moved. Seconded.
Is there a second?
Harry seconded.
Any comments from the public?
Watching. And monitoring for hand raising. Giving at least a pause for people to get their hand raised. See nothing, back to you.
Any comments from the board? This again will be a roll call vote, starting with Tom.
Yes.
Michaela,
Yes.
Harry, Harry, I'm sorry.
Harry did say yes.
Yes.
Okay, thank you. Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution 2024-16 passes. Stella, back to you.
Thank you, Chairman McDermott. So the next steps will be, we will issue guidance to the employing agencies on these resolutions, and then we will prepare communications for employees and non-Medicare retirees, and we will incorporate all these resolutions into the PEB program. Thank you very much for your time.
All right, next up we have Stella, Policy and Rules Coordinator, and Emily, Regulatory Analyst at the Employee and Retirees Benefits Division. Are bringing back several policy resolutions today for voting. Stella and Emily's materials are behind tab number 7. After Stella and Emily review the resolutions with us, I'm going to go ahead and ask for a motion to adopt, a second, invite for public comment, and also discussion from the board till we're ready to vote. And again, we ask for the public comment specific to resolutions after a motion is made and seconded. Please make sure to raise your Zoom hand to give comments that should be specific to the topic. Stella and Emily are going to go over all 10 dual enrollment resolutions first. And then we'll discuss the voting process a little bit more. We'll try and consolidate this a little. Stella and Emily, take it away.
Thank you, Chairman Dermott. For the record, my name is Stella, Policy and Rules Coordinator from the Earth Division. Here are the 10 policy resolution for action. Next slide, please. So Emily DeChain will do a follow-up on the 10 resolutions that address dual enrollment provisions between the PEB and SEB programs. And she will go over some amendments in resolutions PEB 2024-04, 2024-07, and 2024-10. And I will go over the last resolution that would amend the deferral policy for PEB retiree insurance coverage. Next slide, please. This slide and the next slide are included in this presentation, so the board have them available for the policy to discuss. And I will turn it over to Emily.
Thanks, Stella. Good morning, Chair McDermott, members of the board. My name is Emily DeChain, and I'm a regulatory analyst with policy rules and compliance team within PEBB. We have 10 resolutions for you to vote on today in one motion. As Stella mentioned earlier, I am going to briefly go into detail on resolutions 2020-404, 07, and 10. Then I'm going to hand it back over to Lou, who will ask the board to vote on all 10 resolutions in one motion. If we could please skip to slide 11. Thank you. The original slide in our March meeting had the incorrect title for PEB 2021-05. This has been corrected here. So you will see it was changed from resulting dual enrollment when an employee's only medical enrollment is instead to the correct title, which is resulting dual enrollment involving dual subscriber eligibility. And you will see on the next slide that is now reflected correctly. I would also like to bring your attention to slides 13 and 14. We had accidentally had SEB there instead of PEB. So the examples that we included have now been revised to correctly reflect the fact that it should have said PEB instead of SEB. See the next slide. PEB 2024-07, I believe that is on slide 17, or excuse me, 19. Thank you, Dave. 19. The error from the March slides has been corrected. We had accidentally included an extra B when we referred to SEB board. Thanks to whoever caught that, because I know it was a B.
I'll say it wasn't Connie, though Connie would be proud of all of us.
So just a very, very minor change. So that is corrected to reflect that it says SEB. And on slide 20, you will see that that extra B is no longer there. And then if we could skip to slide 23, let's start with 23, please. So in resolution PEB 2024-10, we are asking the board to rescind PEB 2022-02. And here we have included the original text of that resolution for your reference as it was adopted on April 14th, 2021. And then on slide 24, not slide 2024, slide 24, you can see the revised language. I'm going to go ahead and just read that very briefly in its entirety. This slide appears slightly different from how it was presented in the March meeting. So we did this to correctly phrase the intent of rescinding resolution PEB 2022-02. Resolve that effective January 1st, 2025, resolution PEB 2022-02 as adopted on April 14th, 2021 is rescinded. Those are the only changes that I need to go over at this time to ensure that everybody is caught up from the March meeting. If there are no questions or comments, I'll go ahead and hand it back over to Chair McDermott so that he can lead the vote on the resolutions.
And just to explain a little bit more, why this resolution 2024-10 is brought in the way it is. When we looked at the way it was presented last meeting, we were relying on the title as the verb of the sentence. If you think about your grammar, and we didn't actually have clear action that the board is voting on. So it's not substantively different. It's just a cleaner, more grammatical way of the intent that was trying to be conveyed last meeting. So in case you're wondering, there's a lot more red line on that one. I think of it more as a grammar.
Thanks, Dave. All right, if there are no questions or comments, I'll hand it back over to Lou.
You're on mute. You might be on mute.
I'm back.
We hear you now.
There we go. And we're gonna do, Dave, correct me if I'm wrong, we're gonna go through all 10?
I recommend turn to page 9 of your annotated agenda in the middle, right under votes number 1 through 10.
That's what I mean.
Yes. That's the
All right.
description.
Okay. So this is for the board. The first 10 dual enrollment resolutions are lengthy, and they kind of work together as a set. We spent a bunch of time reviewing the underlying proposals the last 3 years or 3 years ago, and these are relatively small adjustments to the core policies approved back then. Stella and Emily read them in full at the last meeting. We received no feedback on these resolutions, and there are no substantive changes to any of the resolutions. So in recognition of time and under Robert's rules, it's acceptable not to read the full text of these resolutions if they've been distributed to the board members in advance of the meeting. I'll note the final resolutions were also distributed Monday evening for public review and published on the Healthcare Authority's website Tuesday morning. Do any of the board members have concerns if I do not read the full text of each of the 10 dual resolutions?
Well, some heads nodding that they do not have that concern.
Yes, I was watching you, Elliot. I was like, yeah, what is she gonna say? She's gonna be like, oh, we're reading these suckers. I have to tease you even if I'm in Arizona, just a little. All right. So additionally, for the same reasons in this instance, I'm gonna suggest that we vote on all 10 of them as a set at the same time in one motion. So if any board members want to vote on each of the resolutions separately, I'd appreciate discussion on the voting process now before we set up and entertain a combined motion. So are there any concerns with this approach?
General head nods that there's not a concern with that approach.
Excellent. All right, we're going to entertain a motion to adopt all of the following resolutions. Resolution PEB 2024-01, amending Resolution PEB 2021-02, employers may waive enrollment in medical. Employees may waive enrollment in medical. Resolution PEB 2024-02, amending Resolution PEB 2021-03, PEB benefit enrollment requirements when said benefits are waived. Resolution PEB 2024-03, amending Resolution PEB 2021-04, resolving dual enrollment when an employee's only medical enrollment is in SEB. Resolution PEB 2024-04, amending Resolution PEB 2021-05, resolving dual enrollment involving dual subscriber eligibility. Resolution PEB 2024-05, amending Resolution PEB 2021-06, resolving dual enrollment involving a PEB dependent with multiple medical enrollments. And Resolution PEB 2024-06, amending Resolution PEB 2021-07, resolving dual enrollment involving a member with multiple medical enrollment as a dependent. Resolution PEB 2024-07, amending Resolution PEB 2021-08, PEB benefits automatic enrollments when said benefits are auto disenrolled. Resolution PEB 2024-08, amending Resolution PEB 2021-09, enrollment requirements when an employee loses dependent coverage and said benefits. Resolution PEB 2024-09, amending resolution PEB 2021-25, PEB continuation coverage eligibility for employees' dependents. Resolution PEB 2024-10, rescinding resolution PEB 2022-02, employees may waive enrollment in dental. That's a mouthful. Is there such a motion to adopt this set of 10 dual enrollment resolutions?
So moved.
Thank you. Is there a second?
Second.
Are there any comments from the public?
Finley, real quick. Give everybody, anyone an opportunity to raise their hand about any topics of any of the subject matter of the 10 resolutions. See nothing, back to you.
Any comments from the board? All right, this will be a roll call vote, starting with Tom,
Yes.
Michaela,
Yes.
Harry,
Yes.
Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. All the resolutions pass. And again, appreciate you not making me read all of them. Thank you. All right, let's see here.
Last resolution. Slide 6. The last resolution, PEB 2024-11, amends resolution PEB 2024-04, deferring PEB retiree insurance coverage when the subscriber becomes eligible for the employer contribution. This resolution is to include SEP benefits, and we received no stakeholders feedback. Are there any questions from the board? No questions from the board? We'll hand it back to Chairman Brennan.
All right, just a moment.
Page 20.
I just want to make sure I didn't skip through stuff. All right, we're going to take a vote on resolution PEB 2024-11, amending PEB 2022-04, deferring PEB retiree insurance coverage when the subscriber becomes eligible for the employer contribution. Resolve that PEB retiree insurance coverage will be automatically deferred when the subscriber becomes eligible for the employer contribution towards PEB or SEB benefits. The subscriber will be exempt from the deferral form requirement. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the audience?
Watching for Mackenzie. Checking. No hands are raised. Don't want to move too fast or too slow. But everybody's had an opportunity, so back to you.
Any comments from the board? All right, this is going to be a roll call vote, starting with Tom,
Yes.
Michaela,
Yes.
Harry,
Yes.
Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution 2024-11 passes.
The next steps will be to issue guidance to the employing agencies on these resolutions, and we will prepare communication for our members, and we'll incorporate these resolutions to our program rules. Thank you very much for your time.
Excellent. Dave, I noticed we're a little behind schedule, but a break is scheduled after the next presentation. Do we want to move the break to now?
That works for me, and I've seen good body language in the room supporting that decision.
Excellent. Let's go ahead and we'll resume at 11 o'clock. Thank you, folks. I'm missing out on all the fun. I'm missing out on all the fun in the room.
You are, there's several more board members out of the room than in the room at the moment, so we're ready to start.
Oh.
All right, folks, let's go ahead and find our seats and get going again.
Yeah.
And next up, we have Ryan Ramsdell, UMP team. We only have screw off time when I'm in the room.
Oh.
When I'm sitting here in the condo by myself. Where in Arizona am I? I am in Tucson.
Oh, lovely.
Yeah, a little bit of elevation keeps it a little cooler. Nice little place we're at. All right, Ryan Ramsdell, UMP team manager, and the employees and retirees benefit division is going to present on some benefit design changes in the PEB program. The resolutions that Ryan is introducing are not scheduled for a vote today, and his materials are behind tab number 8. Ryan, good to have you with us.
McDermott, members of the board. My name is Ryan Ramsdell, and I'm going to go over a pair of benefit design opportunities that you will have a chance to vote on for resolution in May. Next slide. So I'll be covering diagnostic and supplemental breast examinations as one, and the other is a diabetes management program. And these will be proposed at board resolutions that plans that. So the UMP diagnostic and supplemental breast exam coverage. This is a change related to the UMP plan for PEB. The intention of it is for diagnostic and supplemental breast exams to be covered at no cost share to the uniform medical plan members. What cost share means is typically with our UMP plans, you typically see a co-insurance amount. I think the key word here is diagnostic. So for those that are familiar with breast examinations, there is a preventative benefit that all of our UMP plans benefit from. Those typically come at no cost share in advance of your deductible. In this case, what they're attempting to do is leverage off of Senate Bill 5396, which was passed by the legislature in 2023 and was implemented for the fully insured plans January 1st, 2024. Something I need to call out is the second bullet point under benefit change. As you all know, with high deductible plans such as CDHP, there are certain requirements related to the tax exemption status that make the application of this benefit slightly different for high deductible plans. And I will speak to that a little bit when we see the resolution. Next slide. So the resolution, as you can anticipate voting on next month, is that beginning January 1st, 2025, diagnostic and supplemental breast exams are to be covered without member cost share to uniform medical plan members or in-network services. And in fact, that will change next month to essentially in-network and out-of-network. We confirm that, so I'll make an adjustment. As I mentioned in the previous slide, UMP consumer-directed health plan CDHP members need to meet their deductible before the plan will pay any portion of the claim. So those members will still benefit from the no cost share component, but with high deductible plans based upon federal guidance and stands around the deductible arrangement and the tax exemption components. They will first meet their medical deductible, and then after that, they normally have been confronted with the 15% cost share. They will not see that cost share any longer. Any questions on that?
Hi, just to make sure, does this apply only to active employees or what I'm beginning to understand is Medicare covers certain things for retirees. So can you explain the situation here?
Yes, I've confirmed that this particular benefit arrangement is applicable to all UMP members. So retirees would see that as well as retirees with Medicare. Of course, Medicare pays primary.
So when you say, or not you, but when it is said diagnostic and supplemental breast exams, does that include like MRI, ultrasounds? Like what's included in that? And then can you give an example of something that would not be included in that?
I might have to get back to you on what might not be included. included. The actual bill and the bill report stipulates the components that are covered. So what you should contemplate is that the COCs already designate preventative breast exams, you know, age 40 and above and so forth as being under the preventative rate. So that is kind of the first phase. Then we move into the diagnostic or supplemental. Those are typically services that follow that initial preventative service. And that is where the cost component comes into play here. If you give me a moment, I can probably, or if you'd rather I follow up with the board after, I can do that either way. I can either pull the bill report now or what would be your preference, Dave?
Let's do follow-up after.
Okay. So I will present that to all the members for review. There's, I think, a list of 4 or 5 in the actual bill report that they specifically call out.
Do you think it'd be beneficial to reference the bill in the resolution? I don't know if it would be or not, so that it's clear what is specifically covered rather than, well, wide open here. I mean, I don't know, just suggesting.
Certainly can consider adding bill, reference to Bill 5396 into that resolution. I can make that update.
Yeah, I mean, appreciate that feedback, Gary. When Ryan highlighted that there was gonna be a shift from in-network services to out-of-network services, that stemmed from a way a question was asked last week at the sub-board meeting on a similar. And so, you know, anything that the boards think of, you know, we'll certainly look at if that makes sense to put in here, and either way, come back to explain how we're reacting to your feedback, but we'll put that on the list of possible things for revision here.
Other questions? You've given me just enough time to answer a portion of the question. So the bill report related to this bill, beginning January 1st, 2024, remember it was something that was enacted for the fully insured, but we are looking to establish parity with our UMP plans. Diagnostic breast examinations means a medically necessary and appropriate examination, including an examination using diagnostic mammography, digital breast tomosynthesis, breast magnetic resonance imaging, or ultrasound that is used to evaluate an abnormality seen or suspected from a screening examination for breast cancer or detected by another means of examination. So that is the bill's intent, but I will still circulate that after the case as well.
And we'll put in the materials for when we bring this back in May for action in the appendix, a copy of the bill, just to make it available, be more easily available for everybody.
Next slide. So the UMP diabetic management program. This benefit change is UMP to begin offering a diabetes management program to the PEB program members. As a reminder, this is an alignment effort. We did implement this arrangement for the SEP program members, and we want to again, have parity between the programs. UMP would offer Omada's virtual diabetes management program to all PEB program UMP members aged 18 and older who have a current diagnosis of type 1 or type 2 diabetes. Any questions on this benefit? Okay, next slide. So proposed resolution for the UMP Diabetes Management Program is beginning January 1st, 2025. The Uniform Medical Plan will implement a diabetes management program. Slide. So we will seek any feedback that the board would like to provide. Email address is in there as per usual by April 22nd, and then we will bring any feedback back on May 9th, as well as the resolution for action.
Where could we find information about what is within Omada's virtual diabetes program?
We have some stuff on the HCA website. I'll circulate it to the board. We do the kind of the components of this arrangement is a lot of it is related to coaching, peer support. They typically do have digitized weight monitors and so forth. So a lot of it is weight management. There's a meal tracker component, a health coach, peer groups, and interactive lessons that are part of this. It is an application-based arrangement. And I will see if I can't provide some links so that you can read into more detail on this. They're using it in all other, several other aspects. I think KP is also making use of this program. And we use it as a preventative program as well.
And I'll just clarify, I think personal interest is around kind of the cultural relevancy around the coaching of what food is considered recommended for diabetes management.
Thank you.
Elliot?
Just a clarification question. Does this benefit apply to retirees as well?
Would be applicable to all UMP members.
I'm sensing a theme, Elliot, to your questions. That's gonna be helping us think about how to incorporate that proactively in our future presentations. So just acknowledging that. The theme is noted. For you and anyone in the public who's watching and participating that way, because I know that we've had a lot more retiree engagement and your questions probably are some of their questions. So we'll make sure to learn that lesson quick.
Any other questions for Ryan? Thank you, sir.
Thank you.
Next up, Stella's going to come back and present us annual rulemaking briefing for the PEB program. Her materials are behind tab number 9.
Good morning, Chairman Dermott, members of the board. For the record, again, my name is Stella, Policy and Rules Coordinator for the PEB Division. I'm going to go over high-level information on this year's rulemaking and highlight the most significant changes and rulemaking action we are considering making. No action is needed from the board for this briefing. Next slide, please. Here's the tentative rulemaking timeline. In May, we will file proposed amendments, CR 102, and distribute new rules for public comments. And in June, we will conduct public hearing and adopt final rules, which will be the CR 103s. And the permanent rules will become effective January 2025.
Stella, I'm just thinking for people who might not know the Administrative Procedures Act, CR 102 and 103 are just kind of the short form for the rulemaking process and what the actual steps are. So that's what those are referencing. Those are part of state law on how state agencies enact rules.
Thank you, Dave. The focus of this year's rulemaking is divided into 3 different areas. We will implement the 13 PEB board policy resolutions that the board just passed this year, and if passed, there will be another 6 policy resolutions related to the UMP Classic Medicare Plan enrollment and eligibility related resolutions, as well as we will implement several laws that were passed in the 2023 legislative session. And we're adding clarity to rules to better administer and manage PEB benefits as identified by staff and stakeholders. And we are also making amendments within HCA authority. Next slide, please. From the 2023 legislative session, we are implementing Senate Bill 5700. This is the agency request legislation that updates our agency statutes. We are making global changes by updating the definition sections in all 6 chapters of our Washington Administrative Codes between the PEB and SEB programs. And we are implementing Substitute House Bill 1804 that allows certain retirees of employer groups to continue participating in PEB retiree insurance coverage. We are adding a new WAC sections to describe what options for continuation for continuing health plan enrollment are available to a retiree of an employer group that entered participation in PEB or SEP insurance coverage. And we're implementing House Bill 1008 that changes the definition of separated employees. It includes PERS Plan 2, CERS Plan 2, and TERS Plan 2 members who separate from employment on or after January 1st, 2024, and who are age 55 with at least 20 years of service. They are eligible for PEB retiree insurance coverage to either enroll or defer if they meet this eligibility criteria without the requirement to immediately begin receiving a monthly retirement benefit. Just a note, we are also running emergency rules related to implementing substitute House Bill 1804 and House Bill 1008 this year before we adopt these rules with an effective date January 1st, 2025.
Elliot, do you have a question?
Yeah, I looked this up in the bill report for 1804. Could you define PEB employer group? I know it has a specific definition in this context.
I can describe it in a lay way unless you have a very technical. I'll cover it. I won't cover the statutory definition, but in general, if you know, state agencies, higher education institutions, they're mandatory participants in the PEB program. But local governmental entities have the ability to contract with the healthcare authority and opt into the pool. And that all those entities, whether a library district, a water district, a fire district, a conservation district, a transit district, insert district, except school district, can join us. And that umbrella term for all of those entities is we call them employer groups. And now we call them PEB employer groups because we also have sub-employer groups. But it's that broader term that we use to cover, describe everybody who's voluntarily joining.
Because I get questions on that from those groups as well, or have retirees.
Yeah, and in this instance, 1804 there were a couple of actual employer groups in different parts of the state that when the employer left, it prompted these individuals to not have continued ongoing access into the PEB pool, and this bill was designed to address that scenario. I believe it was in the Douglas, Chelan County area as well as Snohomish County last year.
So as an example, the Washington Federation of State Employees, my employer, is an employer group covered by PEB. Even though we're not state employees, the RCW allows for employer groups who represent state employees to be.
So to get for everyone, so PEB employer group, I think there's 6 different statutory parts. It can be a county, city, municipality. It can be tribal government that joins. It can be an employee organization that represents
State employees.
I think it's a civil service employees, but same thing.
Yeah, if you represent county and city though, you can't.
Yeah, right. The health benefit exchange is specifically listed because it's a quasi-governmental agency. And then it used to have school districts, but school districts were out, and the educational service districts, they got moved over to SEB this year. So I think that was my 6. But in general, you're right. There's tribal governments, the health benefit exchange, and employee organizations that represent, insert the right word, employees, civil servant or state employees. Those are also, in addition to local governmental entities, that fall under the umbrella of employer groups. Tom?
So is this a fairly small pool of people we're talking about? Because it's my understanding that if you are a new hiree, whether it's in school districts or in the public sphere, you are automatically enrolled in Plan 3.
I believe that a couple of years ago, the default pension plan that was changed to Plan 2, actually. For many years, it was Plan 3, and then it was 2 or 3 years ago that the legislature changed the default pension enrollment into Plan 2 of the various pension systems. So
Can you still opt into Plan 3 if you don't want Plan 2?
Yep, it used to be that you picked between 2 and 3, and if you didn't pick, you were put 3. Now it's you pick between 2 and 3, but if you don't pick, you're put 2. And no one can pick one anymore. Right, Stella.
Next slide, please. Under administration and benefits management, we're amending our premium payments and premium refunds rule to include exclusions when a subscriber is not required to make the first premium payment and applicable premium surcharges in 45 days to begin new enrollment. For example, a retiree who elects to pay by pension deduction through the Department of Retirement System pension retirement benefit is not subject to the 45-day first premium payment to begin PEB retiree insurance coverage. Additionally, we are memorializing an existing process that has been in place for a long time that allows a self-pay subscriber moving from continuation coverage to PEB retiree insurance coverage without the first 45-day payment requirement. This is because they're already making payments, they're already in the system, and there is no break-in coverage. So we'll move them to the new enrollment status without the need for them to meet this first premium payment requirement. And we're clarifying the documentation process in our premium surcharge group regarding spousal expectation due to a change in the spouse or state registered domestic partners employer group medical plan. Next slide, please. And we're amending the rule that describe when may an employee enroll, revoke an election or make a new election under the premium payment plan to include a special enrollment event when there is a substantial decrease of providers in a PEB health plan. We actually added this special open enrollment event last year because we just identified this additional rule to include this year. And we're also clarifying the effective date of supplemental life and supplemental AD&D insurance coverage when correcting enrollment errors. Next slide, please. Under amendments within HCA's authority, we are making global changes to include the term benefit administrators. And we are removing language related to board members of school districts and educational service districts in our PEB program rules because they can now apply coverage through the PEB program on a self-pay basis. And are there any questions from the board?
Everybody, still, I think you just said that last PEB, I think, program replace that.
Oh, so it's through the that program.
Set program, yeah. So it's not that ESD employees, this is about the migration of those populations over to the set portfolio from the PEB portfolio. And benefits administrators, we've gone over the years, we've called them a variety of different words, you know, we say payroll and HR departments. We finally settled on a phrase, benefits administrators for everybody, everywhere. And so we're just starting to globally use that more consistently. Elliot?
I hate to ask this. Example one, amend the premium payment plan. You know, I won't read the whole thing.
Oh, slide 6.
Yeah, would you give me an example of that? I can't imagine this, how it works.
So let's say that provider group and one of our carriers can't reach an agreement on a new rate for the future. You know, all those rate letters that have, you know, termination notices that have gone out the past couple of years, you know, 5 or 6 of them, and one of them actually went to termination. And it was a large health system or a large provider group that suddenly was out of network. The rule that was established last year is that the healthcare authority has the discretion to create an open enrollment for individuals who were impacted by that. The discussion last year was to rest that authority with HCA because it can happen at any point in the year, and then to call everybody together and talk about it. The agency is tasked with administering the programs, but also to make sure that we are in a position to be able to see how the disruption is and scale it with the overall portfolio rather than making many of the SOEs can be initiated by the member themselves. This is one where the agency would host an event. we saw the disruption was significant. So far, we haven't had any of those, but we put the rule in place last year, and this is just another part of the puzzle that's like, well, this is another piece that should be incorporated. But it's all related to if we ever need to host an open enrollment event because there's a large network disruption that's unexpected mid-year.
Thank you, that was very helpful.
Oh,
Back to the retirement systems for just a second. Let's say I was hired in 2004. And would I have received notification 2 years ago, whenever this change was made, that I could switch to out of Plan 3 and into Plan 2 at that point? But were employees notified that they could switch plans?
so my understanding of it is the change was about future new employees. Existing employees, it wasn't about switching within the pension plans, but it was when you're joining state service, that initial election for new employees, the rule would be if you don't pick you're in your initial 90-day election period, then you're put in Plan 2 instead of Plan 3. It was not a opportunity for everybody to switch plans.
Interesting, because when Plan 3, at some point after Plan 3 was incorporated, the state did some calculating and they did some active recruiting of getting people to switch out of Plan 2 into Plan 3. Even offering some inducements to do that.
Aid sharing.
Yeah.
But the change 2 or 3 years ago was a prospective future enrollment for new state employees at their initial election.
No
And what the default is there, not general switching within the pension world. With that, thank you, Stella. Stella's gonna stay here because she's part of the next presentation, but all wrapped up with questions here, Lou.
Perfect. Next up, we're gonna go over the Medicare Plan D option. Ellen Wolfhagen, Retirees Benefits Manager in the IRB Division, Luke Dearden, Clinical Pharmacist in the Clinical Quality and Care Transformation Division, and Stella are going to be coming together to present some resolutions regarding the 2025 UMP Medicare Plan D option for vote today. Materials for the presentations are behind tab number 10. After each resolution, we're going to go through the standard procedure, and we're also going to have another discussion about consolidating some of the votes. Folks, back to you.
Thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Ellen Wolfhagen. I'm the Retiree Benefits Manager. And I'm glad to speak to you today about the UMP Medicare Plan D option. I do want to start with a clarification on the vision, because Elliot, you asked a question about how it applies to Medicare. So I just want to clarify. The Medicare plans, first of all, vision benefits are included in the Medicare medical plans, except for Plan G or Plan F, because those plans are Medigap plans and do not include vision coverage. On the medical.
Cannot include vision coverage, right? It's not that there's a choice there. They structurally cannot include, because that's a question that we regularly get asked for the retiree communities. Can Plan F and G incorporate vision, hearing, and there's a third benefit everyone has about gym memberships.
Yeah.
And none of those could ever be in a Plan F or G. By definition, they can't be.
As a Medicare supplement plan, they could be included as a different type of plan. So the vision benefit varies depending on the carrier and the plan. For example, the United Healthcare Plan benefits for both PEB Complete and PEB Balance are $300 for the vision hardware. UMP is currently $200, and we are looking at the potential of increasing that. And the Kaiser Washington Medicare Advantage plan is also $300. The other plans, Kaiser Northwest, are $200 or $150.
Because there's all this numbers throwing around, we're gonna end up bringing a presentation back to the board in May that just goes plan by plan and Medicare versus non-Medicare / employees, just to get it all out there in a cleaner fashion. So
Yes, and.
thank you for
and just-
highlighting that there is a difference
There is-
and nothing that the board did today would reduce the benefit of any of the plans that have a higher benefit.
Right,
That's
what
the
I was gonna
main
say,
message
yeah.
for today.
Okay, moving on to part D, we're gonna have some, next slide, please. Follow up from my esteemed colleague Luke Bearden on opioid coverage and examples of drugs in the tiers and the average cost share. And my other esteemed colleague, Stella Eng, will go through the resolutions when we get there. So for plan design, next slide, please. What stays the same? The medical benefits are not changed. Nothing that we are discussing is going to change the medical benefits for UMP Classic Medicare. MODA, as you learned this morning for Jenny, is the administrator of the pharmacy benefit, the prescription drug benefit, and Navitas is actually the pharmacy benefits manager. The deductible will remain $100. It does not apply to the generic tier. Remember, there will be a difference in some of the tiers. And the maximum out-of-pocket will remain $2,000. Next slide. What's different? There will be minor formulary changes and minor pharmacy network changes. The changes in cost shares will overwhelmingly be positive in that they will cost less. And in a Part D plan, the cost share is a specific copay, not a coinsurance. So there will be predictability because people will know if it's at this tier, it's at this copay. And now I'm going to turn it over to Luke.
Thank you, Ellen, and good morning, Chair McDermott and members of the board. My name is Luke Dearden, pharmacist with the team here. So I just wanted to answer a few questions that came up at the last board meeting. Tom, I believe this was your question, just to provide some additional examples of drugs under the Part D option by tier or by type. So starting at the top row, we have the preventive or kind of high value generics. They'll have a cost share of $0 per 30 days under the Part D option, and statins are a good example of drugs in that category. Next, preferred generics. Here we have a large variety. A large variety isn't listed on this slide, but there will be a large variety of low-cost generics also available at $0 under the Part D option. I just listed a few here that represent some of the most utilized products in the Medicare population. Third, moving to the higher cost generics, $10 per 30 days. We have some also somewhat commonly used medications in the plan, and I'll note here that some antibiotics would fall within this category at the $10 per 30 day category. And then preferred brand, I think we've all heard of these medications listed via commercials or other conversations. So Eliquis is the #1 brand name medication in the Medicare population, #1 utilized. Ozempic for diabetes, Jardiance for diabetes, Entresto heart failure, and then Trelegy is an inhaler commonly used for COPD. Moving to the non-preferred brand, I struggled finding an example for this that a large percentage of the population in UMP use because there really isn't any medications in this class that a large percentage use. So I ended up using Praluent, which is a brand name drug used for certain types of high cholesterol. I'll note there is a similar drug under the preferred brand here called Repatha. which most members using these types of drugs currently in UMP that's the medication they would be taking. So that would be in the preferred brand tier. Preferred specialty,
Real quick, I think one of the reasons I understood you also had trouble identifying an example of non-preferred brand drugs is generally those aren't covered at all in UMP today.
yeah.
So
correct.
that's the one of the rows on this chart that is reminding people that this is an enhancement of in the Part D idea that mostly these non-covered drugs would now actually have coverage and be a $75 cap. So if it by definition wasn't generally covered without some sort of grand exception or unique exception based on circumstances, there wouldn't be data to identify something that's prevalent in the population. So just
Yeah.
reminding people about that positive aspect of the Part D idea.
Yeah, absolutely. And then I kind of rounded it out with the preferred specialty and non-preferred specialty. These also align with, utilization in UMP, especially Stelara, Enbrel, Dupixent. Specialty drugs are not used often in general, but for specialty drugs, these have some of the most utilization. And also just to remind everybody that formularies are subject to change. This is preliminary, and the final CMS approved formulary will be available in August of 2024. Next slide.
I do have one question.
Yeah, go ahead, Tom.
Under preferred brands, the first one is Eliquis, and then over here on the next slide, sorry, I jumped ahead a little bit there. Preferred brands, it says UMP average cost share for 90 days is $206, and under Part D, $80. So you would see a fairly significant reduction when you look at that, correct? I just want to know, because I know Eliquis is one of those drugs that is also on the negotiations list. So could you see even beyond that further reduction, because now the CMS will be able to negotiate the price of that?
So that's a great question. So it's unlikely the members in terms of cost share would see a reduction in $80 because the benefit design would be $40 per 30-day supply copay or $80 per 90-day supply copay. The plan may see a reduction in total cost of the drug though, and that's something that may lower premiums for members. But it wouldn't necessarily be realized at the copay level.
The other piece to remember, Tom, is the price negotiation impacts 2026. So it definitely wouldn't impact anything for 2025, and even the premium.
Down the road.
Yep. Absolutely. And I'll just highlight as we're about to move on to is if anyone's wondering, needs a reminder as to what the current UMP cost share is, that's was presented at the last two board meetings, but it's also in the appendix of this presentation on slides 30 and 31 for the 30 and 90 day supply. Those were the ones that prompted your question, Tom, to get examples. And so we put examples on, and then we just, there's only so much real estate on an 8.5 by 11 page. So if you want the comparison of the current, for anyone in the public or board, it's in the appendix because we presented it last week. Back to you, Luke.
Thank you. So this slide, UMP Medicare average cost share per 90 days. Harry, I believe this was to answer your question. And this shows the UMP average cost share per 90 days in plan year 2023 for Medicare members, comparing it to what the cost share would be under the Part D option per 90 days. So you'll see the preventive high value, $0 in the Part D plan, also pretty close to $0 under UMP. For the high value generics, it's right around $1 or a little over $1. There's a little bit bigger advantage for preferred generics. 450 was the average, versus also 0 in the Part D option. High cost generics, there's also an advantage. And then you're right, Tom, preferred brands is where members will definitely see the largest cost share advantage. Next, opioid follow-up. So I believe this was, Michaela, your question, and you asked how did the 90-day cost share limits influence opioids, and can opioids be filled for a 90-day supply and under the Part D option? And the answer to that is it is possible to fill opioids for 90 days. However, the Part D option would employ strategies that facilitate appropriate opioid use, including quantity limits. There are real-time notifications to the dispensing pharmacist concerning, is it a high-dose opioid? Is this member receiving opioids from multiple prescribers, which increases risk? Are there drug-drug interactions? And then additionally, members who have not had an opioid prescription within the last 180 days upon a pharmacy claim look back will be limited to a 7-day supply. However, there are exceptions for that for members who may have cancer or in palliative care or long-term care.
Luke, I just want to check, you verbally said 180, but the slide says 108. And I think I checked with you before, it really is 108.
It is 108 for this. Yes, thank you.
Yeah, it's such an unusual number that it lends itself to thinking it's a typo, and because you said it the way that's natural to say, I wanted to draw attention that it really is 108.
This might be a really ignorant question, but is someone who is biologically able to give birth eligible to be a part of Plan D, Part D?
So Part D is a Medicare plan, so they have to be over age 65 or
There we
disabled.
go.
I mean, they could be
So-
eligible by
okay.
disability. So-
Yeah, well, and the question being around like the 7-day prescription of if you give birth with a C-section, the idea of having to go every 7 days to get an opioid
Yeah.
while caring for a child and having major surgery is just kind of a like, and obviously not for this, but just kind of a call out of like, is there a way to highlight that inequity of the impact it might have to someone who's part of this program who normally isn't identified as part of that program, or maybe a small group?
Yeah, that's really good feedback. I appreciate it. I also, Elliot, I heard you had a question about, what is an opioid, which is a great question, and I wanted to also address that on this slide since we're talking about opioids. So generally, a really high level way of explaining what an opioid is, it's basically they're a family of drugs that all work in the same way, primarily within the brain, and they all create similar effects, namely sedation, pain relief, respiratory depression would be another one. There are both prescription and non-prescription opioids, but all of them have, a risk of dependence and addiction, which is why all of the prescription or most of the prescription ones are Schedule II substances, and then the non-prescription ones like heroin, as an example, is a Schedule I substance. Does that answer your question?
Thank you. But I think you mentioned something that I think is important for people to know.
You turn on your mic. Thanks.
Yeah, there is something important that you mentioned to me there. Just because something is a controlled substance doesn't mean it's an opioid. Is that correct?
Yes, that's correct. There are a lot of drugs, primarily, if you're thinking about drugs for sleep, like Ambien, is a good example that, are not opioids. However, they do still have some level of risk of, dependence, which is why, they're still scheduled, substances. But not necessarily Schedule II substance. It can be Schedule 2 through 5.
Thank you.
No other general questions? You know, we wanted to do just a very high level summary of the conversation of the last 2 months, answer the questions, and then move on to the policy resolution itself.
Good morning, Chair McDermott, again, members of the board. For the record, my name is Stella Ng. I'm the Policy and Rules Coordinator for the PEB division. In the earlier presentation, I've included the board statutory references in tab 7, slides 5 and 6. So those are not included in this presentation. And we have 6 resolutions for action today. So here are the 6 resolutions, and there are 2 resolutions, PEB 2024-19 and PEB 2024-21 with slightly revised versions. So I will go over those with you. And if we can go to the first resolution on page 12. Resolution PEB 2024-17 addresses UMP Classic Medicare Part D coverage, and we received no stakeholders feedback. Are there any questions from the board?
Just because this is the main resolution. This is the benefit resolution for transitioning from credible coverage to Part D. So when Stella says we didn't receive feedback, she means in the PEB and SEB policy inbox as for the exact wording of this resolution. I'm sure the board is very aware that there's been a lot of feedback, town halls, letters that you've received as part of correspondence on the concept that is the embodiment of this resolution. But for anybody who's in the public who might be interested in speaking on this resolution upon a motion in a second, this is the resolution about the benefit design change that is that the board's considering today. So just wanted to squarely put that, and also be letting people know that you can go ahead and start raising your hands in anticipation, just to streamline the process for being able to take any public comment that might be related to that topic. So with that, if there's no more questions, we'll hand it over to Lou for this benefit one, and then after action on this, then Stella will go over the eligibility set.
Thank you, folks. All right, we're getting ready to vote on resolution PEB 2024-17, UMP Classic Medicare Part D coverage. Resolved that the UMP Classic Medicare prescription drug benefit will change from credible drug coverage to Part D Medicare drug coverage effective January 1st, 2025. Is there a motion to adopt? Is there a second? Are there any comments from the public?
So far, I tried to give people a little bit of advance notice to start raising your hands in case. So far, we don't see anyone. I know that, just a reminder, we did hear public comment last meeting as it was introduced from several organizations, and the board has seen a lot of feedback and correspondence. So we do have a hand. I knew if I talked long enough, somebody would raise their hand. I just want to make sure they have an opportunity. We can see it's
Christine Clark.
Christine Clark. Go ahead. You are on mute at the moment, though. Still checking. You're still on mute on our end as far as we can see. Is there anyone else Mackenzie who's raised their hand? If you're on a phone and not online and calling in, try *6. We're gonna do our IT support right here. from our state HR manager.
Go on mute.
Still on mute, Christine. Checking everything on our end just to see.
And we now have another hand, Annette.
Okay, we'll keep working on trying to get unmuted. We'll check back in on you, Christine, but we have another comment from Annette. Go ahead. Is Annette on mute? You're not on mute, Annette, but we can't hear you at the moment.
Better go.
Oh, there we go. We're starting to hear you. Go ahead. Can't hear you, Annette, either. Heard you for a brief moment, though.
You're in it?
Yeah. We just heard that. We'll just check again, Christine or Annette. Stella just leaned over and said, oh.
I didn't know you were talking to me. Annette Barca, I am with WA Retired, and I'm also a Sheba volunteer. The question comes up with the Part D Medicare coverage. Is this a plan that exists for other people in the state, or is this a specific Part D plan that's for the PEB Uniform Medical Program?
This is Ellen Wolfhagen. This would be specific to people who are enrolled in the UMP Classic Medicare plan. So this is an employer group waiver plan. And as such, it is different than an individual plan that would be available in the commercial market.
So Annette, the individual would have to be eligible and in the PEB retiree pool in order to access this plan.
And in UMP Classic Medicare.
And then in UMP Classic Medicare within our.
And is MODA also a regular? I don't recognize MODA as being a provider of a plan that exists currently in the state of Washington. Is this a plan that exists in other states as well?
MODA is the third-party administrator of the prescription drug benefit today in the Uniform Medical Plan and has been the third-party administrator for almost at least a decade or longer. So they are the administrator of the current pharmacy prescription drug coverage that members in UMP Classic Medicare experience, and they would continue to do that tomorrow. Is that helpful context for your question?
So it's sort of like what Regions does with UMP and Primera does for Plan G. Okay, that makes sense. Thank you.
Yep, just one refinement. UMP has two TPAs, Regions for the medical side and MODA for the prescription drug side. So many people say, oh, I have Regions. They really have the Uniform Medical Plan and they have both Regions and MODA because MODA covers the prescription drug side of UMP. That's a very common source of opportunity for clarity for everyone is when people say they have Regions, they really mean they have Regions and MODA because they have the Uniform Medical Plan.
Okay, thank you.
Yep. And Christine, did we get your mute button sorted?
Right, it's down, but we have another hand up from Mary.
Okay, we'll turn to Mary, whose hand's up.
Hello, can you hear me?
Go ahead, yes.
So I was on this call last time and I thought I remembered that this change will impact the premiums in a good way for the participants. Is that correct? And if so, how can you give us a percentage of how much lower the premiums would be?
Can you state your name for the record?
I'm sorry, Mary Demange.
Okay, hi Mary. Yes, we've described, we can't do the exact amount yet. We'll be moving into the rate development process over the next 60 to 90 days, but we have described what else, I think the phrase we use is significant downward pressure. We're trying not to have people fixate on a specific number at this point, but some of the original modeling had very significant levels of downward pressure on the premium. That's the best I want to answer your question for today. Because we're trying to not have people focus on a specific number, because we won't have a specific number until rates are developed later in June, early July.
Yes, thank you. I really appreciate all the work you've done, not just on this, but on everything. So thank you.
Thank you, Mary. Any other hands, Mackenzie? And Christine lowered her hand, so I think Chair McDermott, we have observed public comment for this resolution.
All right, thank you. Is there comments from the board? Well, I have one comment. I'd like to thank the PERB staff and Dave in particular for moving this forward. Costs have been a significant issue for retirees. It has been a big, huge deal, and we've struggled with it for years. And so I'm really glad to see this action being taken. So really do appreciate this, Dave and crew. This is going to be a roll call vote, and we're going to start with Tom.
Yes.
Michaela,
Yes.
Harry,
Yes.
Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution 2024-17 passes. And the next, we're going to go ahead and do a similar activity as long as folks aren't object in any way. There are 5 more resolutions, and we're going to talk about voting those as a block. So Stella, back to you.
Thank you, Chairman McDermott. Resolution PEB 2024-18 addresses the automatic enrollment when the Medicare enrollees who are enrolled in the UMP Classic Medicare did not make an election during this year's annual open enrollment. That they will be automatically enrolled in the UMP Classic Medicare with the Medicare Part D drug coverage with an effective date January 1st, 2025. And we received no stakeholders' feedback on this resolution. Are there any questions from the board? No questions from the board.
Keep going, go through them.
Okay, so then I will go through the next resolutions. Resolution PEB 2024-19 addresses the split account situation related to UMP Classic Medicare plan, that any non-Medicare enrollees on the account will be enrolled in UMP Classic. And we are bringing you a slightly revised version based on internal feedback to be clearer on the intent that a subscriber selects coverage not only for themselves, but for the dependents on the account as well. So it reads, if a subscriber selects the Uniform Medical Plan UMP Classic Medicare plan, any non-Medicare enrollees on the account will be enrolled in the UMP Classic.
And as a quick reminder for people who might not be remembering what the phrase split account means, that's the phrase we use to describe when you have a couple where one is Medicare eligible and one is not Medicare eligible. They end up, they can't, the non-Medicare eligible person by definition can't be on the Medicare plan unless they're disabled. But that's what we just coined that phrase, split account, for ease of reference.
Are there any questions from the board before I move on to the next one? No questions, I will look at resolution PEB 2024-20 that addresses the gap months before UMP Classic Medicare plan begins. And we received no stakeholders' feedback on this resolution. Are there any questions from the board? So next resolution. Resolution PEB. Thank you, Mackenzie. Thank you, Scott. So resolution PEB 2024-21, amending PEB 2022-03 Medicare Advantage Prescription Drug Plan enrollment during that month. We have a slightly revised version based on internal feedback. As they pointed out during the last board meeting, flexibility is important because circumstances can change. So we are removing the words Uniform Medical Plan, UMP, in the middle. So the resolution would read, if a subscriber elects to enroll in a Medicare Advantage prescription drug MAPD plan, and the required forms are received by the PEB program after the date the PEB retiree insurance coverage is to begin, the subscriber and the enrolled dependents will be enrolled in transitional coverage as designated by the director or designee during the gap months prior to when the MAPD coverage begins. Are there any questions from the board?
I'm just gonna add context again. Last meeting I highlighted, when we have an auto enrollment type rule, we actually usually don't try to specify the plan name. And so when we were looking at this, we realized that we probably shouldn't say the plan name. So, you know, but I know that seeing words like UMP Classic stricken on a slide can be scary to people. It really is about just trying to have that flexibility because circumstances can just change. And if a plan name changes or like, you know, what, there's a million ways that things can change. So that's all that is really.
So this will be the last resolution. Resolution PEB 2024-22 addresses when a subscriber is involuntarily terminated by a Medicare Part D plan. That the subscriber and the enrolled dependents will be enrolled in a PEB medical plan as designated by the director or designee. And we received no stakeholders' feedback on this resolution. And are there any questions from the board? Yeah, I hate to do this, but can you give me an example of why someone would be disenrolled under federal law? There are a couple of limited circumstances when a subscriber will be required to be disenrolled from Medicare prescription drug coverage because they are no longer eligible to remain enrolled in the plan. So for Part D plan, if somebody is living outside of the plan service area, that will be like such as the United States, the 50 states, for over 6 months, then the Medicare Part D plan must disenroll the subscriber. And another example would be if the subscriber is enrolled in Medicare Part D plan, and then the person fails to pay that Part D income-related monthly adjustment amount called IRMA, then CMS will require the Part D plan to disenroll the subscriber. So those are some of the limited circumstances where the plan will be required to disenroll the member. Welcome.
So I think it might be helpful to consider more specifically the term director, because I don't know if that's a PERB director or ACA director, or there is no PEB director per se. I think in an earlier resolution, it was clearly stated the HCA, which I understood was the director. So I think it would be helpful here to know who the director is.
Yeah.
Not by name, but positionally.
Yeah, here, I think this is the phrase that we, I think, use consistently. Once it gets codified in rule, director has a definition in our rules, which is the director of the agency. So currently the director of super, but it is the agency head director. And that's actually also defined statutorily, whatever when Stella highlighted earlier the cleanup legislation, it used to be administrator or part of the cleanup because everybody was confused because some of the rules and statutes said administrator when we all call it the director today. But director is, when you roll it up into rule and statute, it is the agency head. But I do believe, Stella, that we've tried to be very consistent in bringing the same phrase, but it does, it's good at least for the record to know that that is what that means. It means the agency director, or in that instance, if the director designates somebody else sort of like the chair of the PEB board is the director or designee, and Lou is the designee today. And we have a document that's filed where she delegated authority today. If anybody ever asked what his authority to chair this meeting was, those types of things exist, but it does mean the agency.
Any questions from the board? No questions from the board, and I'll turn it back to Chairman Dermott for the vote.
All right, thank you, Stella. Now with these 5 Medicare enrollment resolutions, they work together as a set. We reviewed each of the resolutions in March and Stella read them in full at that time. We've received no feedback on these resolutions and there are no substantive changes to any of the resolutions. I'd like to make another run at doing all of these at the same time. And I'm wondering if there are any concerns if I do not read the full text of the resolution at 2024-18 through 2024-22 from the board.
And
Seeing no-
there's not a concern.
Excellent. All right. Then let's get a motion to adopt all of the following resolutions. Resolution PEB 2024-18, automatic enrollment, UMP Classic Medicare, annual open enrollment 2024, resolution PEB 2024-19, UMP Classic Medicare enrollment, resolution PEB 2024-20, UMP Classic Medicare enrollment during gap months, resolution PEB 2024-21, amend PEB 2022-03, Medicare Advantage prescription drug plan enrollment during gap months, and resolution PEB 2024-22, when a subscriber is involuntarily terminated by a Medicare plan, Part D plan. Is there a motion to adopt these set of Medicare enrollment resolutions?
So moved.
Is there a second?
Second.
Are there any comments from the public?
We were gonna check for hand raising. Would be anything related to any of the 5 resolutions. Not seeing any hand raises, so I think you're okay, Lou.
Any additional comments from the board? All right, this will be a roll call vote, starting with Tom.
Yes.
Michaela,
Yes.
Harry,
Yes.
Elliot,
Yes.
Kurt,
Yes.
and Lou, yes. All the resolutions pass. Thank you so much. And now, hang on. Next up,
Back to Stella.
back to Stella.
Thank you.
Easy enough.
So the next steps will be, we will issue guidance to the employing agencies on these resolutions, and we will prepare communications for our Medicare members. And we will also incorporate resolutions into our PEB program rules. And I will let Ellen to talk about the implementation timeline.
Thank you. So just to go over, this was also presented last month to the board, but today is the board vote. The formulary finalization, which takes place with approval from CMS, will have been probably in August. MODA will have customer service available to answer questions beginning in the fall, including a drug lookup tool, which will help people identify the potential cost. And open enrollment will be in the fall, and then go live will be January 1, 2025.
As we kind of wrap up, it seems anticlimactic given the amount of work. And I just want to acknowledge, especially if members of the public are just tuning in for the first time, it feels like all of that went very fast. And I've definitely had that question before in the past. There is a ton of work that has gone behind this, and I would be remiss if I didn't also try to acknowledge in some way the amount of work that agency staff has put forward in getting us to this point, helping members of the retiree community understand the proposal, and helping the board through multiple presentations this year. We usually don't have a big substantive type of question like this kicked off at the retreat and voted on by April. It's almost like a board season has already happened and we're only halfway through. in some ways. And so a lot of work has really gone into this. There is a lot of work to come still, from an implementation standpoint. There are many, many, many things, to continue on. And I do appreciate the level of questions and support that the board and stakeholder community was giving over the last 30 to 45 days. Because quite frankly, it was helpful to try to start to do some pre-implementation work and not lose 45 days. That is a lot of time in a small window that we already have. And so just being able to anticipate that this was being so well received gave us confidence in trying to lean a little forward into getting, not falling behind in implementation. And so just really appreciate both the staff support getting us to this point, the board support, stakeholder community support, and we're really looking forward to bringing you rates in June. And how often do I get to say that in Medicare in the same sentence? I don't think I've ever said that in my tenure as the director since 2017. So very looking forward to that part of the next board season. Those are my kind of concluding remarks on this part.
Dave, is there a process now? I mean, just, we've approved it, I suppose, the result. Does that have to go to the CMS or somebody? I mean.
Yes. So I would remind, April 11th was the anointed day because there are timelines that go very fast after this in order to actually implement. There have to be final approvals of the remember, we're kind of piggybacking on a part of a plan that has kind of preliminary CMS approval is the way I see it, because it's been used in the past by MODA in other parts of book of business, but there's a little bit of like enhancements and refinement that have to get filed, but it's like, it has had general prior good response from CMS. And so we're, that's how we're able to try to hit a 2025 actual implementation for impacting 2025 premiums. But yes, there are CMS filings that have to happen that MODA will be working on and that we're working with them on, but we needed a board action today in order to hit 2025. And so that is the work to come that is already underway, along with IT programming and communications rewrites, everything that goes with these types of changes. Any other questions? You, for public comment, general public comment, Luke?
Thank you, sir. We've now reached the public comment section of the meeting. If there's anyone on Zoom who would like to provide comment, please raise your Zoom hand and we will call on you in order.
Please monitoring. And yet. Okay, we do have. We have 2 members so far. We'll start with Tony. And you're on mute.
Yes, thank you. Tony Long, and I'm a member of RPEC. I just want to thank all of you very much for all the effort that's been put into this for the past long time, as you know, year or more. Really appreciate your response and all the research that's gone into this and pulling it together. So it's just a thank you comment. Thanks very much.
Second. Amy.
Thank you, Chair McDermott and members of the board. My name is Amy Fortier. I want to say also thank you so much for all the work that's gone into this provision. Would like to suggest something to the timeline, which is to add an evaluation of the Plan D performance and the additive changes that have gone into UMP Classic for 2025, so that we're able to see if the goals have been achieved, both for hopefully lower cost and access to the correct pharmaceuticals. Second comment has to do with the benefit design, the UMP continuing benefit design. Appreciated the presentation from Ryan Ramsdale. which is implementing the legislative changes. And if there were to be any additional additives for future UMP, how would that, what would that look like and how would that begin outside of legislative mandate? So I'm curious about that because of interest in potential other benefits that can be positioned into this lower cost benefit, such as long-term care or silver sneakers. And those would be my comments. And again, my thanks for all the work on everyone and both the public and the staff for HCA. Appreciate it. And of course, the board. Thank you.
And we have,
From Annette.
and we have a third public commenter, Annette.
Yes, I just want to add my thanks to the other people's comments. The amount of work that's been put into this, not only by the board, but by the staff members, I think is going to make a lot of members and enrollees happy. I know that unplanned, but I recently involved with a number of health issues that I didn't anticipate, and the benefits of the UMP plan that I have is unbelievably great, and I really appreciate how much the benefits that are provided are available for us if and when we need it. So thank you for your hard work, and thank you for looking at coming up ways to make this plan more viable in the future. Thank you.
Annette, and just checking if there's anyone else. All right, I think we have completed public comment, Luke.
Outstanding. Our next board meeting is going to be May 9th with the same format of attendance in person or via Zoom. Any final comments before we adjourn, Dave?
Just a reminder that yes, the agenda says there's an executive session, but I announced at the beginning of the meeting that we would not actually be having the executive session, but we will in the future. At the next meeting, we know that we will bring back Ryan's resolutions on UMP benefit design. I also anticipate having a presentation about benefits 24/7 and health stabilization gone. I've done some overviews at the beginning of meetings in the past 2 meetings, but we wanted to bring a presentation back. We'll also be working on plan by plan explanation of the vision benefit in the future state to help people, ourselves included, be less confused about who gets what, where, when. And then kind of maybe an unexpected topic for you, we're going to be talking about auto insurance. You may or may not even realize that we have a marketing agreement about auto insurance discounts, and it hasn't been talked about in a really long time. And so we're going to bring that back to the board. It is a part of your benefits authority that may not be intuitive, and we want to bring some space back to talk about that part of the portfolio in May. So looking forward to talking about auto insurance. So that's what I have. Elliot has a question for me.
Yeah, actually, one of the members who just spoke, Amy, brought up a really good point. Let's say for UMP new Plan D, she has questions about how would other new benefits be added, and other than going through the legislative process. I'm not clear on that, so I would like to know that as well.
We can put that on the to-do list for discussion. Thank you. And that's all I have, Lou.
All right, folks, appreciate all the work today and everything that's led up to today's meeting. Dave, your staff, excellent work, and we will see you all next time. This meeting is adjourned. Thank you so much.